Hello, hello,
Hello, hello. Sir, can you able to hear me?
hello, check. Hello, 1, 2, 3, mic testing. Hello, check. Hello, check, 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 check. Hello, check. Hello, check, check. Hello, check, 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 check. Hello, check, 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 check. Hello, check. Hello, check, check. Hello, 1, 2, 3, check, check. Hello, check. Hello, hello, check. Hello, check, check. ಸರ್ ಇವರು ಮೇಡಮ್ ಅವ್ರು ಕೇಳಿ ವಾಲ್ಯೂಮ್ ಕರೆಕ್ಟ್ ಇದೆ ಇಲ್ಲಿ ಆಚೆ ನಾನು ಹಲೋ ಚೆಕ್ ಹೊರಗೆ ಹಲೋ ಚೆಕ್ ಹಲೋ ಐನ ಮಹಾರಾಜ್ ಓಕೆ ಡನ್ 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 ஒருத்தர் பேர் கூட நமக்கு தெரியாது
Hello, hello.
இந்த பொண்ணு பேர் என்ன
Excuse me. Hello.
இந்த பொண்ணு பேர் ஹலோ ஹலோ
YouTube check your mobile. Live started.
Hello, hello.
Hello, hello, hello,
Hello, check. Hello. Yes.
Welcome to Indian Myeloma Congress 2023 Radiology Workshop. I am Associate Professor in Radio Diagnosis and Intervention Radiology, St. John's Medical College, and with me Dr. Chandana, Professor and Head, St. John's Medical College. So, multiple myeloma is the second most common cause hematological malignancy, and it should be treated at the earliest. And imaging plays a pivotal role in diagnosis and few speakers with us who wants who will explain about the imaging perspective and the importance of imaging, various imaging modalities, diagnosis of multiple myeloma, and prognostication of the disease. With this note, I will welcome Dr. Director and Senior Consultant, Nuclear Hospital, Bengaluru. We welcome you, sir. Kindly give your inputs.
Thank you, Sai. I would like to thank Dr. Harminan sir, Chandana, and organizing team for giving me the opportunity. Today I am going to talk do's and don'ts of PET-CT for MRD in myeloma. I don't know how much I can justify the title, but I can definitely tell you the importance of in MRD in myeloma. MRD is minimal residual disease. Why it is important? Even after achieving complete response, significant effect on the uh, progression-free survival and overall survival after achieving the complete response. You can see the graph. There is a clear difference in the MRD negative patients who will do good in terms of overall progression-free survival as well as overall. This is study published by Munshi et al. This graphs indicates patient who are having MRD negative good in terms of overall progression-free survival and overall survival. Even subset of complete response who achieved complete response, in them also the progression-free survival and overall survival is better if patient achieves MRD. MRD generally is by conventional techniques, multi-parameter flow cytometry, oligonucleotide quantitative polymerase chain reaction, next generation flow cytometry, next generation sequencing technique. And then after achieving MRD by these tests, patients relapse after some time. So we need to find out why they relapse, because these tests assess the MRD in one bone marrow region. What are other regions? Since myeloma is a patchy distribution in the whole body, there can be some residual disease other than the pelvic bones. So solution are new techniques like cell-free circulating DNA sequence analysis and MRI. Today I am going to focus mainly on CT. Generally, 10 millicurie of FDG and 45 minutes, 60 minutes. And normally we do from vertex to mid thighs. In myeloma, since it involves any of mainly for the metabolically active regions, low dose non-contrast good enough. Because of patchy dissemination of the disease, MRD evaluation in bone marrow could sometimes false negative results in the presence of minimal disease after elsewhere in the body. And it is not uncommon to have extramedullary disease in the body. PET can detect active metabolic lesions which are there in the other sides of the body that can be the reservoir for myeloma relapse even after achieving the MRD. MRD is associated with outcomes, but still patients relapse. So in those patients, it's helpful to detect sites. IFM 2019 trial showed double negative, that is MRD negative by as well as achieve better progression-free survival than the MRD are not good when compared to double negative patients. Alonso et al. Published in Hematology 2019, MRD PET both if negative 4-year survival is better best as well as positive. In some patients MRD can be positive, still PET can be negative. That is a false positive negatives can be there in the PET CT. In those there is no significant difference in the 4-year overall survival, but they have a poor shorter progression survival who are having MRD positive PET negative. We'll come to PET negatives, false negatives in coming slides. FDG positivity after the first line of treatment is the most affecting factor on progression-free survival and overall survival. That is why this is important in assessing the MRD, even if MRD is negative in by conventional techniques. This is some literature I want to quote. Bartel published study the examine prognostic implications of PET CT and MR in patient with newly diagnosed multiple myeloma. He assessed based on focal lesions. Focal lesion is defined as focal metabolic activity in at least 2 slices without any response in terms of focal lesion and extramedullary disease after chemotherapy. Overall survival as well as the progression-free survival is good compared to residual disease in the patients. Nani et al. In 2000 published prognostic value of the PET CT after 30 in patients after autologous stem cell transplantation. Relapse is more in patients who are having negative PET CT after stem cell transplantation when compared to PET positive. The difference is 27 months to 18 months. Usmani et al. In 2013 did a prospective study impact of day 7 PET CT when compared to baseline PET CT to change the is it significant to change the early to bring the early change in the treatment response, especially in patients with high risk disease. He compared baseline study as well as day 7 PET CT. If persistence of more than 3 lesions, he calculated number of lesions. If more than 3 lesions is there, day 7 PET CT, free survival is less when compared to patients having the number of 4 lesions. See the survival is 78% versus 58%. Overall survival is 87 versus 82 versus 63%. Try to establish the some objective that is the PET CT evaluation. He took like focal lesions, calculated the number of focal lesions, and he applied criteria to give a score. Less than 3, more than 3 he considered, and number of lesions 3, more than 3. Patients who are having focal lesions more than 3 and bone marrow score more than 3 do less better when compared to the patients who are having less number of focal lesions as well as the less bone marrow score. Bone marrow score 3 is similar to DV score, which is less than or less than liver activity. If it is more than 4 liver than the liver activity, it is 4, and if it is twice the liver activity, it is considered as 5, very much similar to the DV score. And Serlampos et al. To detect prognostic significance of PET CT at 6 months following the induction therapy. He did time to start new treatment in terms of PET negative and PET positive patients. Time to new treatment means that based on the when to do that. If patient is negative after 6 months after induction therapy, time to start new treatment is 6 months when compared to PET positive patients, which is 30 months in a complete response patients. This is response. He compared response, very good partial response of working group with positivity and negativity. Patients who are having less than the partial response with PET negative, they have overall survival of nearly almost like 10 years when compared to less than very good partial response with positive finding positive PET after 6 months, only just 1 year. So coming to false positives, there are many situations where patient can have associated inflammations, infections, and fractures can happen in myeloma. After healing, if they are displaced fractures, still there can be some biomechanical and reparative changes, still they can show some activity. We should not interpret them as positive. Our bone marrow biopsy, we have to be careful interpreting the bone marrow biopsy site, and chemotherapy bone marrow activity, and use of growth factor which cause focal stimulation of the bone marrow. We have to be very careful with patient history. If you find a focal lesions, we have to consider these growth factor injections. False negatives can happen with patients taking steroids and hyperglycemia, as well as in patient is in 10 to 15% of the patients. This can happen status. Many people have tried with traces like lipid traces, amino acid traces, or immune PET, and zirconium DFO, deoxyamine daratumab targets cluster of people they have studied. still you need more higher number of people. There are there are some disease and methionine. They have showed mixed results. These are small number of patients. We need more studies with a larger number of people. It gallium pentixafor definitely will be useful in a patient who are having MRD positivity but negative pair. It may be the false negative. In those cases, pentixafor may be useful, but availability and the cost effectiveness we have to look into. Putting the PET CT, we have to whether it is MRD negative or MRD positive, and how to formulate the report. Number of lesions, at least based on literature, we should comment less than 3 or more than 3 active lesions. Are there any extramedullary lesions? What is the criteria SUVmax cutoff to progressive survival and survival? There is one study, Jamani et al. He considered 4.2 as the cutoff mark. If patient is having more SUVmax more than 4.2 and more than 3 lesions at the baseline study, they are going to have a poor progressive survival as well as the overall survival. And can we establish the DEVIL criteria to the myeloma patients? And by following these criteria, can we reduce the variability and make the standard inter-observer reproducibility can be there? I hope this in the panel discussion we get some conclusions or decisions regarding this. With this, I would like to conclude my talk. Thank you very much. I'm happy to take questions. Yes.
Just wanted to ask, routine clinical practice, you put in the last slide for
No.
reporting?
I haven't seen anywhere and have followed. Only to just formulate standard format of the report mentioning like MRD, how many lesions, are there any extramedullary lesions, at least in the conclusion. I think we should try to inculcate that.
Sir, one question.
Any more questions?
Sir, is there any such response criteria like dwellers in a non-Hodgkin's lymphoma or lymphomas? In myeloma, do we have any such scoring system to
No.
know?
People have tried to extrapolate the DEVIL's criteria only.
Okay.
As of now.
Because very difficult. For example, interpretation also is important. For example, even DEVIL's 1 or 2 also sometimes they'll report it as a positive PET. So very difficult to interpret unless if you have something like good.
There is no response criteria. There is one group from Italy. They formulated impetus criteria, overall myeloma evaluation to reduce the inter-observer variable. They have mentioned about skull lesions separately, lymph nodes, extramedullary disease, and cortical lesions and marrow lesions. They try to give one is less than around 1 to 3 is 2, 4 to 10 is 3. Like that numbering they have given, but it's very robust to follow if you have a high case load.
So I think
That is just to minimize the inter-observer reducibility, nothing to do with MRD.
I think again we'll compare with the mediastinal blood fluid.
Yeah, DEVIL's criteria, that is what.
Same thing. Thank you.
Thank you so much, sir.
Dr. Reddy, can I ask
Yes, sir.
one question?
Sorry.
Yeah. Actually, it's very good to listen to you. My question is related to that. The myeloma defining event is like they have to have one osteolytic lesion.
Yes.
So, like suppose the lytic lesion is there in the CT and it's not showing the uptake, average uptake. What do you think about it? So, whether you call this is the always question like when we do for the and low dose CT and then patient go for the say the lesion you call it myeloma or non-myeloma. Second question is related with that.
think that the all myeloma lesions so
will take. And if it is not a diagnosed case, difficult to characterize if there is no metabolic activity in a lytic lesion. We have to rely on further evaluations.
oh, so conclusion that some of the myeloma lesion can be the
Negative, false negative. So
FDG
in 10
negative.
to 15% of cases, there can be a lack of exokinase. They
Yes.
can show false negative PET CTs. Maybe if you still suspect myeloma in those cases, maybe if traces gets available, new traces, we can like pentixifar and zirconium, which targets CD38 will be useful. I think I have one image. Yeah, this is the image. If you see, the D image is done 1 week prior to the A image. D image is FDG PET CT. There are no lesions in scapula. If you see, there is a lytic lesion, but in the zirconium daratumab scan, there is multiple lytic activity. So false negatives can be there. Maybe new traces, if they become available and cost effective, we can try at least in those false negative patients if you are still strongly suspecting myeloma.
So will you give it like it's a myeloma but it's FDG negative?
It is a diagnosed.
Is
If
it
it not a diagnosed, we can categorize. Yes.
Okay, thank you.
Can I ask a question? Sir, how do you interpret FDG activity in a myeloma patient at a particular site?
Osteolysis. These are like focal lesions, marrow lesions. There has to define that there has to be at least slices of without lytic lesion on the CT. You have to consider these as focal marrow lesions. This is where MRD has effect. Yes.
There is the increasing use of PET-CT for the initial evaluation of myeloma day by day because of non-availability of whole body MRI or whole body low dose CT by centers. Do you think it is a justified?
Yes, it is costly in India, but people are preferred. And in tier 2 cities also, that now there are many PET CTs are coming up.
In institution, it is as low as.
In tier 2 cities also, when I joined nuclear medicine, of course, I did not even know what is nuclear medicine when I joined. Just before joining, I came to know. I did my MBBS from Kannur Medical College. I was expecting like around 10 years, PET CT will come. In 13 years, one PET CT I already started this last week only. One more PET CT is like many tier 2 cities, even in Karnataka also, Shimoga and all, they have started PET CTs. There are further more PET CTs are going to come into tier 2 cities also. Yeah,
Coming with PET CT, whole body MRI or whole body low dose CT because it is very rare centers which have this facility.
because in whole body low dose CT, we may miss the marrow lesions.
And if you do the part wise MRI, the whole cost will be more than PET
PET
CT.
CT, yes.
Will prefer for
Yeah. Yes.
Thank you so much, sir.
Thank you.
Thank you for that. So next presentation will be role of MRI in myeloma challenges by Dr. Sunita Palasamudram. She is a senior consultant neuroradiologist, Department of Radiology, St. John's Medical College and Hospital, Bengaluru. We welcome you, ma'am, to give your insights on role of MRI in myeloma.
You can start.
Everyone. So for the next 20 minutes, I'd be talking on imaging of multiple myeloma from a radiation on the role of imaging modalities, keeping with the current guidelines, and the the common and rare complications of multiple myeloma, and also learn about a few different routinely in clinical. To start, we all know that it's a multiple myeloma is a hematological malignancy, monoclonal plasma, and it evolves from a range. It can be asymptomatic and it can be organ damage. So the imaging modalities are mainly to assess the light bone lesion to detect the early stages of bone marrow infiltration. So this is done by MRI and low dose MRT and also FTG PET. So in this talk, I would be mainly focusing on CT versus MRI, and only the FDG PET will be shown in a couple of complementary cases. So the CT, as you know, have replaced the skeletal survey X-rays. Previously, it was the skeletal X-rays which were done to evaluate multiple myeloma, and now it is being replaced by whole body CT. And MRI, of course, is very good to detect the early bone marrow infiltration. And we also have something called MyRAS. And I would just touch base on it, but one has to be very much aware that this is only in the clinical trials. We do not practice. So people have done, they have formed groups like RESIST groups and RENO groups to do this in the research trials, but nothing is still encountered or come into the clinical practice. So guidelines, we need to follow this protocol. So this is a whole spine T1 and whole spine T2 with stir or fat suppressed T2 weighted images. Apart from that, we need to do a whole body vertex to knees T1 weighted sequence. Similarly, whole body vertex to knees axial diffusion weighted sequence with ADCs, and whole body vertex to knees axial T2 weighted images. So as I told you before, this is only in the clinical trials to assess the response and diagnosis. This is still not, practice, and in routine clinical practice, we only use T1, T2, and stir images with axial images for routine clinical diagnosis. So the reasons for not including this are these patients are very old and they have pain, and this entire sequence will take 1.5 hours, and it is very not very real to expect them to cooperate for the entire from the cost effective nature of MRI. So one caveat here is most patients who have low back pain, and in most of the centers they undergo sagittal screening with axial screening at the disc levels, and coronal stir is only done at lump. So this leads to a lot of disadvantages. The marrow without weighted sequence. In most of the centers, one is never done because everything is thought to be a degenerative disease, and most of it is routine T2 survey. Also, whole because of these pitfalls, in a significant population, we miss a lot of cases of multiple myeloma. So this is one thing we should again, CT versus MRI. CT has a risk of ionizing radiation, although we are doing with degenerative changes and osteoporosis. It is increasingly difficult to detect marrow changes. Not very useful to detect early marrow disease. Is the best of skeletal complications. Everything can be again, if you see a solitary plasmacytoma on an MRI and you see a couple of other marrow lesions, it can be So it is also a very good investigation to predict the outcome and follow. So before we go to the cases, I would like everyone to pay attention to the normal marrow. So as I mentioned, T1 is the sequence of the marrow. Now it will on T2 and now it is on T1 and then the information. So on T1, the T marrow, what we see in the vertebra should be more than that of the intervertebral skeletal muscle. So this is a normal marrow because this is hyper. The vertebral body is more wide or higher than the intervertebral discs or the skeletal muscle as we see. Now depending upon the T1, it can be hyper or hypo, and then we can correlate. It doesn't add any value isolatedly, and then if the same lesions are of any sort of, it has a kind of malignant potential, they show up on images. On otherwise, they don't show any hyper images. So this is how normal marrow should be, put on a MRI. So with that knowledge, this is a normal or abnormal marrow. So what do we see here? We see the vertebra is intervertebral disc and the skeletal muscle. So this would be a normal marrow. So when we know normal marrow, how it is one, it's very easy to cover. These are the different marrow infiltrative patterns of multiple myeloma which we see on MRI, and again each one is a T1 image. So all have been described image. So what we see here is some focal hypointense lesions, and this is a focal type of marrow infiltrative multiple myeloma. This is a diffuse disease. As we see, there is a diffuse hypointensity on T1 weighted images. This is focal on diffuse. So this is a diffuse disease and there is which we see as salt and pepper appearance, where it is diffuse nodular, very small nodular pattern, which on the background of hyperintensity, it shows small tumor hypointensities as we see. So in routine practice, the most common pattern which we get is focal on diffuse pattern and salt and pepper pattern. So before going to the cases, I would like to tell that all these are the patients presented from 50 to 60 years of age, and the presenting clinical history of low back pain. So in this case, we saw that this was an elderly patient, and this we saw that there were multiple lesions here, and luckily the T1 was also done, and these lesions were significantly T1, and there are many lesions like that. We see in vertebral levels, there are lesions which are hypointense on T1. Now these are iso to hyperintense on T2, but we are more concerned about T1. So now these on-stir images are hyperintense. So these are all the lesions. So because of this, but the CT did not show any lytic lesions. So our differentials were metastasis versus multiple myeloma, and this finally turned out to be a case of focal on diffuse pattern of multiple myeloma. And now we go on to case 2, where this patient presented in low back pain, and on this T2 weighted MRI, we saw that there are multiple factors in the vertebra, and there is no hyperintensity on stir. So because there was no hyperintensity on stir, we presumed that this could be osteoporotic. We went ahead with the T1 was not done because it was thought to be fracture. So on CT, we found that there was a particular pattern in one of these lesions here, and the cortical struts were very prominent, and there was dispersion of the entire vertebra with this prominent trabeculae. So this gives a kind of mini brain appearance, which is well described with multiple myeloma. Furthermore, there are multiple calvarial lesions which are lytic and with no surrounding sclerosis, very classically described in multiple myeloma. And because we saw this mini brain appearance, even without a T1, we favored the diagnosis of multiple myeloma and then osteoporotic fractures and of course metastasis, and this turned out to be a case of multiple myeloma. We move on to case 3, where we have again a patient with low pain, T1 and T2 hyperintensities on T1 weighted images, cluster hyperintensities in the corresponding T1 hypointense images. So because of this, again the two important are multiple myeloma and metastasis in this patient population. Once we found a lesion here in the kidney, and this prompted us to give metastasis as the more likely possibility, and this turned out to be a case of metastasis from renal cell carcinoma. Interesting case again, patient with low pain, patient of aged 55 years, T1, multiple hypointense lesions on T1. Again, the T2 is variable, ISO2 hyper. So some of them showed enhancement on post-contrast. TER was not done here, and because of this, because of the age group and the kind of infiltrative appearance, he favored multiple metastasis. And, to the surprise, so intraosseous lymphoma is a very rare tumor. It is more common in long bones rather than in, and even in the spine, the secondary lymphoma is more common than the primary lymphoma. The secondary lymphoma, so if lymphoma is somewhere in the mediastinum or something, then it is possible to, but as such, primary lymphoma, intraosseous lymphoma is something very rare. But this case is to highlight that even although rare, such kind of surprises can be found sometimes. So this is a very classic appearance of a plasmacytoma. The location is very well described, especially the sacral location is one of the very commonest location for a plasmacytoma. So in when you see a soft tissue lesion which is hyperactivated, it is, we have diagnosis. We have plasmacytoma, we have lymphoma, we have giant cell tumor, we have metastasis. So in the order of, you know, the age, the location, other lesion, we favor one over the other. So this turned out to be a case of plasmacytoma. And again, to reinforce the mini brain appearance, when there is this plasmacytoma gives a very typical pattern of the vertebral body with giving an appearance of a mini brain. So this mini brain, again, the sensitivity is only 80% and specificity is 97%, which means to say that routinely encounter all the cases. When we encounter, yes, it is possible that it is a case of plasmacytoma or a multiple myeloma. Prior to the even for years. The very rare complication of multiple myeloma is this extramedullary multiple myelomas. Can involve. We encountered a case where the patient where the patient has many like here, the patient presented with multiple cranial palsies. So we went ahead to do an MRI brain with extracorneal lesions of the brain parenchyma here in the petroclival location and here around the arcs and around the convexity. So based on background, we came to the diagnosis that this is an extramedullary multiple myeloma, and this is very rare, especially the CNS involvement is very rare. It is only 0.7% of cases, and most important is it is associated with a very poor prognosis. The second common complications of compression fractures, it's important to look for these compression fractures and also tell how the diagnosis got compression, and for this again MRI is a imaging modality. So the response treatment again, as described in the MyRATS group, it is done with a specific detailing. This is again not an is because we don't do whole body MRI, we don't do diffusion sequences, but it is good to know that such and such group is existing in the trials, and they are trying to aim at evaluating a very good post-treatment response on MRI. So as per this criteria, there is something called high likely to be responding, and 1, 3, and 5 are very easy to tell, because when we see the myeloma lesions being replaced by fat, we tell that the patient is responding well. Or when there is decrease in number, we say that the patient is responding well. Similarly, when we tell stable, there is no change between the previous MRI and the present MRI. Now, when we tell it is progressing, again it is very easy, because when we find new lesions, new fractures, new complications, extra matters involvement in different sites, we call it high likely to be progressing. But these two are a little bit tricky: likely to be responding, likely to be progressing. So for this, they have come up with a criteria. They say that if the lesion is more than 25% but less than 40% increase from ADC from the baseline, we tell it likely to be responding. Similarly, likely to be progressing when there are some equivocal new lesions, when there is no change in the size, but even when there is some ADC values, when it is showing some increase in the ADC values, we say that it is likely to be progressing, and so on. So this is an example. This patient has a focal on diffuse myelomatous lesions, as we see by the arrows represented here. This is a diffusion image, and this is 3 months after see the focal disease, and it is treatment. So in keeping a lot of research happening in also where try to prove that these lesions are very active and it is progressing. Similarly, also there's a lot of again the imaging one should always remember metastasis, especially from breast and prostate, because they do not have soft tissue with it. Osteoporosis fractures, although we have a criteria to differentiate, sometimes can be overlapped, and marrow-proliferative disorders like thalassemia, myeloproliferative disorders. To summarize, if one thing anybody wants to take from this talk is T1 is the important sequence to evaluate marrow. We cannot call any marrow-proliferative lesion without looking at a T1 sequence. And T2 and STIR complement the T2. So the patterns of MRI are important to remember. It can be focal, diffuse, focal on diffuse, and salt and pepper types. Brain appearance can be seen, but the sensitivity is relatively less. But as once you see, the specificity is more, that it is a plasma or multiple myeloma. Important differentials is something which everybody should remember. It can still be a metastasis, it can still be an osteoporotic fracture, marrow conversion results. It's not useful for diagnosis for the follow. With this, I end my questions. So, sir, for the diagnosis, T1 is enough. Is something which you want to, when you want to, because even in the common differentials, its role is there in the, yes. So when we follow them up, most of it is a normal MRI.
You don't see lesions most of the time.
Yeah, we don't get you know, right now I have not seen anything because when we get requesting for spotting so that is how it's sent to pet and then it goes on some
Where that we are isolated, we don't come together, so we many a times the clinician is affected.
yeah.
We routinely do PET MRI, so I can tell about it. In my talk also, for small myeloma and MGUS, runs whole body DWI. That's what MRI.
To pick up more and more cases.
Madam, I'm Dr. Sadash. I'm a clinician, madam.
Yes, sir.
So thank you. It's a very wonderful, actually, informative talk.
Thank you.
Especially MRI. I think as a clinicians, we never see that one. All the actual, whenever we see, simply we'll see there's something report. Most of the times, the MRI will use in spinal cord compressions. Actually, this is the most one thing. And very rarely, I think, scientifically, once you read all the scientific papers or publications, we'll do MGUS, I think, to wherever we want to take clinical decision, in the sense treatment start, because MGUS sometimes we don't treat the patients. They just only follow-up is mandatory, that's all. If we go to something smaller than multiple myeloma also, we don't initiate the treatment immediately unless we have something specific criteria, either bone marrow, something plasma cell more than 60%, some FLC ratio, and this imaging technique more than 0.5, I think one focal lesion with 0.5 mm. So I think in that situation, wherever we want to take a clinical decision to start therapy, it is mandatory to do the something, spend some time and energy and money also. Otherwise, I think unnecessarily this a patient may not require treatment if you start therapy based on some lesions is not correct. I think we have good modalities, highly sensitive and specific modalities. But as a clinician, as all of us, and we should know that when to use which technique. That's the most important thing. Unless there's a, I think maybe this workshop intent is only that one. But your talk is very nice, madam. I think definitely in the panel discussion, all other things. But again, what you said is MRI is more sensitive for, I think, intramedullary disease. Because
Marrow lesions, yeah.
Because bone marrow. There's plasma cytoma or multiple myeloma, whatever it is. The multiple myeloma is a disease of bone marrow of plasma cells. So it's a highly sensitive technique to pick up bone marrow disease wherever there's a high active plasma cells in that.
Yes.
So I think wherever we have some doubt, especially this marrow discrepancy between the clinical or laboratory, definitely we have to do something, spend some time.
Yeah. So there were cases even in when we saw when because the patient back pain, we always give multiple myeloma versus METs with whatever lesions and with whatever techniques we do, and it's a clinician's call now. Next, what to do? Because many of the patients after that they cannot afford to go to any kind of treatment. So there are some parameters like which is high in metastasis, again hypercalcemia, but sometimes we see that both are equivocal. Even then, there is a confusion even at that point of time.
For that, I think the multiple myeloma, there are defining events are there, madam.
Yeah.
Biochemical, imagological, and pathological.
Correct.
So in that, I think we'll coordinate the three things. Then only we'll start.
That's why even when I discuss with the clinicians, they after, because of the patient's concern that they cannot afford more, at that point even the diagnosis is very difficult to give.
Compared to whole body low dose CT versus whole body MRI, when we are doing only whole body low dose CT, do we miss something?
Yeah, definitely. See, CT only shows lytic lesions. It doesn't show any marrow disease. Early marrow disease, diffuse marrow disease is a miss on CT. So ideally it shows a lytic lesions, but it has a pattern. Now if you see that mini brain pattern in some of them, then you can tell that, but it is not that in every case of myeloma you see. So early disease is always marrow disease. So if you want to pick, it is MRI first. CT can complement it. Yes.
We'll discuss this thing over the panel discussion. So thank you, madam, for the wonderful presentation.
Yeah, thank you so much.
The next presentation is on role of low dose whole body CT in myeloma challenges by Dr. Mahesh Prakash, who is Professor Radio Diagnosis and Imaging, PJMR, Chandigarh. We welcome you, sir.
Thank you. Thank you very much. Good morning. First of all, I'll thank at the outset, I thank the organizers for inviting me for this short lecture. So, like, as we were discussing, actually, it's very, very important to coordinate with the clinician as well as the other people, the colleague of the other departments like the nuclear medicine, to have actually the things. So actually the important point I want to highlight here again to tell everyone that all modalities are equally important. We cannot replace one modality, even like the X-ray, the radiograph. We are not able to replace those radiograph. So every modality has a pros and cons, and we have seen like the lectures also. Even the PET CT, like we were thinking that PET CT should be the first imaging modality. There are a lot of false positive, false negative points also. Even Dr. Sunita has shown one of the cases where the MR was quite less sensitive, and was case number 2, and the CT showed so many lesions, and MRI could show only the vertebral fracture, osteoporotic fracture. So that's why these are eye opener for everybody, that not one modality is equal. Another point I want to highlight as the sir is sitting here, that if you do like we all know that the MRI detect the changes of myeloma earliest, but if you consider the guideline of International Myeloma Working Group, they are not thinking of the changes what we can see on MRI. As I was discussing yesterday, that we know that the MRI detect the myeloma changes early in the medullary cavity, but they don't initiate this treatment if they start. So the guideline include the osteodendritic lesion, and which can be seen either on CT, low-dose CT, or in PET CT. So that's why even we know about it that the MRI is most sensitive. It detects the changes early, but that's not considered in the IMWG group for the initiation of the start of the treatment. That's why these things are important if you're considering the working group. So I'm not going to tell about some of the things which already discussed about it. We have the CT, the advantage, the wider availability, low cost, and fast acquisition. That's why the group, the International Myeloma Group, has said that we should consider the CT scan as the first modality because of these advantages. And this is the IMWG group of the recommendation. What are should be the technical parameters, and what I do in our institution is this. And we have a 128 slice machine. They said the working group that should be more than 16, and the tube voltage 120, and then the current should be 50 to 70. We use around 20 to 34, so we are using less, and equally like we are providing the equally good images, and like we can say it's like quite readable images. So we have the low dose, we are increasing, like giving the radiation to the patients are less in comparison to the working group. So we all know that this is the non-contrast study, and the patient has to supine. Acquisition time is usually slow. Like if you compare it with the other study, like the PET CT or the MRI, is quite is very like quick scan area usually take from vertex to the below knee, and some people now are saying that you have to take the till toe also. These are the imaging finding. We have already seen some of the the cases here. Like we usually find the lytic lesions, diffuse osteopenia, then the osteoporotic fractures, and obviously it's difficult to say whether it's a malignant fracture versus the osteoporotic fracture. The extra-osseous component, we can see about it. Marrow infiltration is seen, but not as good as in MRI. So I'll show some of the cases here. Like this is the typical pattern of the CT scan we can see. So a lot of the lytic lesions, the osteoporosis, which can be seen in most of the bones. And there can be soft tissue like the component which extend from the bone also and extend to the soft tissue. And these are some of the lesions. If you consider the soft tissue window, some of the lesion, focal lesion, obviously you can see in, but obviously the sensitivity of picking these lesions are quite low in comparison to MRI. So MRI is obviously very, very good in that. So we have already seen the advantage of the low dose about it. But the topic was the challenges. What are the challenges when we do the low dose CT scan? And these are categorized in the technical things, what we do in interpretations, and the inherent limitation of CT. So I'll show some of the challenges things. So technical challenge, what are the technical challenges? Like if you want to do the CT scan, the patient's like very, very obese, and then if you consider the same guideline by the International Myeloma Group, then obviously may not be sufficient to provide the good quality images. Sometimes the patients have the various fractures, and the typical the position is we cannot do it. So obviously there is a limitation of doing the CT scan. Sometimes we can get a lot of like prosthesis, like hip prosthesis, or the some of the screw in the spine, or because patient has already some of the fractures. Then obviously there are limitations of the scan, the quality. And if you do because I have seen that some of the people are doing very less milliamperes, the tube current voltage, and then they usually get the very poor image. I will show some of the cases. So these are some of the technical challenges, like if the patients have a bilateral these prosthesis, and you can see a lot of hardware, the artifact, and sometimes you can miss many of the lytic lesions because of these artifacts. So this is some of the technical the challenges we can put. And some of this is if you put it very low current value, tube current, then you see like very kind of it's not very good quality imaging, and then definitely there is a chance of missing some of the lytic lesions. So that's why like it's obviously depend upon the institution what you want to use that tube current, but it should be readable and it should be like adequate. So adequate kind of the images which you can read, and you should not miss the thing. So too low current should not be done. And as I said, that people are using 10 or 15 milliamperes, so that's actually it's not very good. What are the apart from the technical challenges, we have a lot of the challenges, like particularly depend when you are so many of the radiologists are reading those CT scan, and you have to think on this some of the points where like many times there's some normal variant, and we should not miss it. Like, and people I've seen the reports, people just say that the lytic lesions are there, but actually their lytic lesions are because of myeloma or not, and you have to check it. And need to see the evaluation the lytic lesion. So as I said, in the myeloma group, if the lytic lesion is there, which is showing the sclerotic border, is not considered the myeloma lesion. If the patient has a lot of very severe osteoporosis, obviously we will miss those lesions, and there can be other the challenges. I'll show some of the cases. So these are the area where there's a lot of the lytic lesion can be seen, particularly in the scalp. And I've seen a patient, if you are not seeing the properly in the 3D images, some of the lytic lesion you can say that is probably myeloma. And some of the lytic lesion here in the like a patient has osteoarthritis, and then you can see a lot of subchondral lytic lesions. Then there can be some lytic lesions and the pubic bones, and sometimes this is this kind of synchondrosis. So, and some of the lesion here, like you see, this is the lesion here, this shows the sclerotic border. So not all lytic lesions are due to myeloma. We have to think in that way. So that's why, and this is like need to be like, that's why there is a role of a good radiologist It's not just a simple like any lytic lesion as we consider, because as we see that the myeloma group, they have said that the single lytic lesion which is more than 5 millimeter is considered is a myeloma defining event. So if you just say that these are the lytic lesions, or if you say in the report that we found that the lytic lesion, then clinician that doesn't have any option. They have to start the treatment. So that's why it is very important for the radiologist point of view that they should see very carefully that these lytic lesions are not because of the normal variants or normal other lesions which may mimic the myeloma. So that's why very important, because when we consider the lytic lesion is the CT scan is a very important point for the treatment of myeloma group, then the role of radiologist is very important to say that this lesion does not fitting to myeloma or myeloma. Sometimes we can get a lot of the larger soft tissue component and lytic lesions. Obviously, sometimes it's very difficult to say on the basis of only CT scan that these lesions are just because of myeloma. Obviously, myeloma can be there, but obviously there can be the other differential diagnosis. See, this is the one of the cases where the report was saying that multiple lytic lesions are there, and so see, if you see from there, if you can see from appreciate from there, that it looks like a lot of lytic lesions are there in the vertebrae. But actually, if you see very carefully here, you can, this is the lot of, because this is the lytic lesion which is appearing lytic lesion actually is osteoporosis, and what we are seeing is the bend of the sclerosis at the site of the just adjacent to the end plates. So actually, this is a rugged jersey the spine, whereas because of renal osteodystrophy, and there is the lytic area because of the secondary hyperparathyroidism. So that's why it's important, like if you doesn't know the actual the radiological things, and then you can obviously label as these are multiple lytic lesions, and that's why this is, again, I am stressing that it's important for the people who are experienced, and if you are thinking that you are not very sure about it, at least see the other clinical parameters also on the patient. And this patient was the chronic renal failure patients, came for the low dose CT scan, and somebody reported as a very lytic lesions, and then we could see that it's not because of the myeloma, it's because of renal osteodystrophy. So this is that's why these are some of the challenges area, and only the good radiologist can detect these points. Again, as I said, that the severe osteoporosis also, like this patient has a severe osteoporosis, you can see that only just because of only end plates are kind of the cortex is there, otherwise a lot of the osteoporosis. Again, here there is a lot the very severe osteoporosis, and there is a lot of vertebral compression fractures. So again, here in these cases of severe osteoporosis, you can miss this the lytic lesions. Obviously, this is again a challenge for the radiologist to pick up these any lytic lesion in cases of severe osteoporosis, because there is no bones are like which we can say that the lytic lesions they are not there. Obviously, sometime if you find the kind of the fractures here, so you can't say whether it's a kind of osteoporotic fracture or because of myeloma collapse. In cases here, you can't see because just the some sclerosis and the fracture. But obviously, if you see this kind of cases here, then obviously there is a lytic lesion within the vertebra. There is decreased height. So here you can say there is the osteoporotic, is fracture or the collapse of the vertebra because of the this one, the myeloma. Here you can't say. Obviously, after that the role of MRI comes, where actually it's to differentiate whether there is osteoporotic fracture versus this one. But sometimes the findings are quite easy, and you can see there is a lot of other lytic lesions. So obviously, so you can say that is because of the myeloma collapse. Sometimes, like as I said, that is some of the cases like the myeloma always not be lytic lesions. Sometimes you can see some sclerotic lesion, and this was the case of the osteosclerotic myeloma. So you have to keep in that mind that you are just thinking that where the lytic lesions are there, and you are not able to find out. So this is the case of here you can see a lot of sclerotic area. Obviously, this kind of myeloma is less common, but you can find out. So obviously, this again a challenge until your mind doesn't know, your eyes can't see that, and you just make it as a kind of bone island or something, or you can just say there's some kind of the non-specific sclerosis, and then you just you just put it the report in that way, that probably we are not able to find out any lytic lesions. But obviously you have to know that some of the myelomic lesion can be sclerotic also. And there are some of the challenges we have seen in the previous lectures also. There are inherent challenges like for the CT scan. Obviously, as I said, that the lesions are in the medullary cavity, so it's not very sensitive. Obviously, we can pick up some of the points, so like 10 to 15% cases, we can detect some of the lesions within the medullary cavity as some soft tissue, increased Hounsfield. But here, like obviously, they're not as sensitive as an MRI, and now MRI provides the gold standard for evaluation of any the medullary cavity changes. So see, this is the one case here. This patient come with a low dose CT scan, and see we could find out there is a soft tissue component anterior prevascular space, and the adjacent the manubrium we could not find anything. So probably so on CT scan we cannot say actually this lesion is because of myeloma. And later on, this patient went to MRI, underwent MRI, and then we could see that the lesion was there in the manubrium, and then it turned out to be a myeloma. So obviously, this is the inherent limitation of CT scan, but it's there. So that's why in cases like if you come across this lesion and the clinical diagnosis of the myeloma is there, and you just find out that this lesion, then obviously these are the kind of indeterminate lesions where the osteolytic lesions are not there on CT scan, but the soft tissue component is there. So obviously you have to go, like you have to tell, or you can suggest the clinician that this patient required the MRI to further investigate it. We can't leave this soft tissue as a non-specific soft tissue or the lymph nodal mass or the any anterior mediastinal mass. Similarly, as Dr. Sunita has shown in some of the cases where some of the patients CT doesn't show anything, and the MRI shows so diffuse changes on MRI, typical diffuse pattern, and she showed other patterns also. So this is the inherent limitation. But only the questions remains that, as I said in the initial, if we detect the lesion in MRI, are we able to, like, the patient will be undergoing treatment or not? So that is the usual question remains to all of us. So whether we want to go according to International Myeloma Working Group the guidelines, or we all know that some of the modality has advantage over the other the modality. But that's why I was discussing Dr. Pankaj yesterday also. Do we need to revise the guideline, whether, because they have put it the osteolytic lesion as the guideline to treatment, the one osteolytic lesion, and we know that the MRI or the PET CT or PET MRI, they detect the lesion as earlier than the PET CT scan. So do we think that these guidelines need to be changed or revised according to, if you are, so whether patient need early treatment or not? So it's a kind of for the panel discussion. We need to reach this one, some of the conclusion, whether we want to treat this patient according to imaging the changes which appears earlier, or we just think that the CT scan is the thing which we can consider as an osteolytic lesion for this initiation of the treatment start. So just to take home message that we know that the low dose whole body CT is a preferred diagnostic modality. Obviously there is various reasons I have showed to you the various advantage. That's why the working group has considered is the imaging modality. Initial imaging modality is the low dose CT scan. Still there, we know that there's some can be some limitations are there, but this is the best thing because of the lot of advantage, wider availability, low radiation doses, availability everywhere. That's why the working group have said that probably this is the best thing which we can start. Later on we can think revising the things as we go like in the future also. Obviously their proper positioning, protocol, interpretation, these already are there, and you can modify according to your institution is always there. There are always challenges which I have shown that there are a lot of challenges as not just a simple CT scan. There are a lot of challenges there, particularly the lytic lesions. So not all lytic lesions, as I said, that not all lytic lesion in CT scan is because of myeloma. You need to be aware that some of the lytic lesions are because of some of the other reasons. And you can overcome by this proper knowledge if you have a proper knowledge and the experience. That's why is always importance of the good role of good radiologist. And the CT is indeterminate, then obviously we need to investigate further by PET CT or the MRI or PET MRI. depend upon the availability and the clinicians, the importance. Thank you very much.
Thank you so much, sir. I think low-dose CT is very less centers are doing it, if I'm aware, or is it more
I
centers?
don't know actually why, because the thing is like this is kind of similar the same city. If you have a scanner more than 16 the slice scanner, just you have to put it that we need to have a just the, I think everything is there. I don't know what is the reason. I think it's very simple. I don't. I think but all the radios what we have like. I just said like we do as you are a radiologist also, you know that are like having good the scanners nowadays. Lot of advancement, the software and hardware has been done, and people are like all the younger generation, they are well versed with the imaging things. I don't know why the people are not doing. It's not like different from like, it's not a kind of rocket science. It's just simple. The CT scan, we are doing in the chest the chest CT also. We need to have a 3D imaging. 3D images are available. Like we just to make it kind of 3D. It's not, like, very simple. Nothing. I mean, nothing additional things are required. If you just have any CT scan, low-dose CT scan is can be done.
Yeah, the floor is open for questions.
Yes.
I think in the follow-ups, if you don't have a base, I mean, PET has become now standard of care. If you do only baseline CT in the follow-up, response assessment becomes difficult.
Yes, definitely. That's why I'm saying that. That's why all the modality have the advantage. You cannot like follow up. CT scan is not the indicated. Follow up for PET CT is required. Even the MRI, people
PET
have.
CT and MRI are becoming more important than only CT.
Yeah, that's right.
Because follow-ups will.
Yes, follow up. Yes, follow up. Low dose CT is not recommended. Why is not recommended? Because the actually like if you consider the healing of the myeloma lesion, healing occurs quite late, and what we are seeing is just a osteolytic lesion healing. So that's why it's not recommended. So if you do like healing already active disease, it become inactive in some of the like weeks or something or month, but the radiological changes occur after years. So that's why it's not indicated. Like in PET CT, disease active versus inactive. You can show that these physiological changes, which is not if were there in the previous and after treatment become inactive. So you know that this is a follow up what is happening, and MRD, what is the things which are residual. But the CT scan on basis, this is a morphological the modality, which detect what are the changes which happens structurally, not the morphological changes or pathological changes which is happening. MRI is obviously is much better than the CT. But as I said, that if you just thinking about this initiation of the treatment and the at the starting of the diagnosis of the multiple myeloma, or are you thinking of the modality which you want to get it done in during the follow-up? So obviously they are different. But we are thinking like the myeloma group, they have said that at the time of the diagnosis, the low-dose CT is required. If you want to get the follow-up, that obviously the PET CT and MRI is required. So obviously we should not confuse whether the low-dose CTs are useful for the diagnosis or is for the follow-up. Obviously, they are two different things. For the diagnosis, at the time of diagnosis, low-dose CTs can require. For follow-up, PET CT and MRIs are required.
I have two questions.
Yes, please.
In that sclerotic myeloma, what you showed,
Yes.
was it biopsy proven?
I am not very sure, but it was labeled as it's a diagnosed case of multiple myeloma.
How do you differentiate? I mean, if could it be something else than?
Yeah, that's why you always say like if you think that the only basis of radiology we can diagnose everything is that's not correct. That's a patient of the myeloma, and these were the lesions were detected, and then it was labeled as a multiple myeloma. Obviously, if this patient clinical was not multiple myeloma, we could have labeled as something like bone island or something. But that's the point why I was to highlight that point. That some of the lesions of multiple myeloma can be sclerotic also. Like if you don't know that the point, then obviously you will not label it. That you just say that no lytic lesions are there in this low-dose CT scan, and just you can miss it. So these are the things which if you know in like your mind, then obviously you can put it in the report that this lesion can be because of multiple myeloma.
There is a one OM
Poem syndrome is the poem
Yes,
syndrome.
this was the case of poem
That is-
syndrome.
that is a-
This was case, yes. This, yes.
sclerotic,
Yeah, yeah.
disease in
You're
that.
correctly said. This is the case of poem syndrome.
But even in then,
Like,
Pet, I don't know about the pet. I have not seen it. That the poem syndrome.
but ultimately we'll prove with the biopsy only.
biopsy is needed.
So again we'll do the
Without
bone
biopsy,
marrow
it's
and
difficult.
we'll
See,
electrophoresis
if
we'll
it's a
do, we'll
sclero-
confirm that.
even if it's a Poem syndrome, if it is a sclerotic lesion, and let us say you went ahead and did MRI or PET, and there is no uptake on PET and no signal change on MRI, will you be able to call it as a lesion? I don't think so. You
Even
have
the
to do
even
biopsy.
like if I consider that even sclerotic lesion, the yield is very less. So even the biopsy, you may not get the
Biopsy also.
desired result. Desired result. Yes, sir.
Yeah, the only thing is that when you are making a diagnosis, you take all the other parameters.
Yes.
So it is not only the
Yes.
the skeletal lesion. So obviously somebody has a bone marrow plasma cells which are more than 60%, calcium is high, or renal failure, or anemia is there. So you take all other factors into account when you are faced with this kind of a problem. I think Dr. Mahesh, were discussing yesterday only that MRI is a modality which picks up the changes earlier than CT scan, but IMWG, the International Myeloma Working Group, actually has not made MRI or PET CT as the investigation of choice.
For
Although
initiation of-
we all feel that those are good modalities, and for follow-up, as you said, those are good modalities, but probably one of the reason is that they are costly and they are time consuming. MRI is obviously is a time consuming.
Yes.
Again, I'm not sure how many centers in India are doing diffusion weighted MRI of the whole body. We did that in PGI,
Yes.
but it takes a lot of time, and people are quite claustrophobic actually. Yeah,
One hour.
it is. Yeah, 1.5 hours it takes. So a CT scan is very easy.
Easy.
I write a CT scan, ultra low dose whole body CT scan. It is done within a day.
Yes.
But PET and MRI, 3 months waiting list and other
Yes.
things. So
But in our centers, I think PET CT is done earlier than the CT scan. Sir. In certain areas, I think because nowadays every center they have the PET CT. So I think this is what he says. Sir is saying, but even though this low dose CT is very ideal test before we start therapy, but with the same cost, the same time, we are able to get the best imaging. So people there, as a clinician, we always think the
Yes.
patient should not come for frequent visits for the.
Sir,
special
that's why I'm saying that we know that the PET CT is good, but whether it's included in that working guideline group or not. Well, if you think that this is like good, then we can start at the time of. They have not said that.
It is included, sir, at the 0.5 mm. It's included now. I think it's for defining event.
So when it comes to guidelines, we need to understand many of the people sitting here are part of the making guidelines. So when guidelines are made, so there are two components to it: the academic component of it, and then the feasibility component of it.
Yes.
So when the IMWG prepared the guidelines, in which Pankaj sir and me were also part of the discussions. So basically, we also have to take care of sub-Saharan countries, the remote areas in the country. We are not talking of AIMS, PGI, CMC, Vellore, St. John's. We are talking about 2-tier, 3-tier cities where people might take a long time for them to get these appointments, get the things done. So, as sir brought out, the whole body low-dose CT has a role when we talk of a pan-India or a pan-global point of view, ease of getting it done. In sub-Saharan countries, getting MRI done, it's actually practically impossible to go to MRI center to get an MRI appointment or a PET CT appointment. So when we talk of guidelines, just not the academic component of it, but the feasibility or the resources take a key role while preparing guidelines.
Yes, that's the correct thing. That we have to consider everything. Like if you like patient come for any African country or other Asian country where these are not available, the PET not available, MRI is not available. So we have to always the international group whenever they makes a guideline, they consider everything. And he's rightly said that because of that reason, we know that the MRI is better, we know the PET CT is there, but because of the feasibility and the comfort and the time, everything considering the PET CT, they thought probably that the CT is the one of the best modality. We can rely and we can start the treatment.
I think the guidelines have to be changed in a way that when available and if the cost factors are all similar, which should be the investigation of choice, and when not available, which is the investigation.
yeah, so the Asian Myeloma Network actually has made the guidelines where it is minimal, optimal, and extended. So they have divided into three. That minimal, this is the minimal, this is the optimal, and if the finances are not difficult, then this is the extended. So different different guidelines
Yes,
have actually made
yes, yes,
different
that's
kind of
why.
curriculum.
Even the NCCN has now come out with a resource constraint setting guidelines. So in NCCN, you can see for resource uh, 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 constraint and non-resource constraint settings. And in that, it is clearly written for the resource constraint setting, the low dose whole body CT is there, and for the non-resource constraint, PET CT is there.
Just,
yes,
just a
ma'am.
request.
Yeah, please.
In view of the short,
Huh.
and keep the discussion during the
Sure,
panel.
okay. I'm okay. I'm
Sure.
okay. No problem.
So
Thank you.
we are skipping the tree break and continuing with the next talk.
Thank you. Thank you.
Thank you.
Sorry, we'll have some 10 minutes break.
On popular demand.
So that is all. देखो ना टाइमर अभी फ़िलहाल रहने दो क्योंकि टाइमर में टाइम बहुत जाएगा और ये ऑलरेडी वीडियो प्रेजेंटेशन है 40 मिनट का ही है तो वो टाइम पे 40 मिनट का है तो उस ड्यूरेशन में आपको 10 मिनट कहीं जाना हो तो आप जा सकते हो
Yes, you can get it.
मैं क्या कर रही थी
You wanted to check something. It's okay, ma'am, no problem.
उनको बोलो स्विच कर दे
Is it necessary?
6 नितिन शेट्टी
Okay.
लिखा हुआ है ओके
Shall I cross check once? No one is there, no one is there.
लाइव स्ट्रीमिंग तो है ना भैया
What, ma'am? Nitin Shetty.
वीडियो प्रेजेंटेशन ऑन कर दो भैया
No,
लाइव स्ट्रीमिंग
Dr. Nitin Shetty. Welcome back. So now we will go to the second half of the workshop. So this is on vertebroplasty, his experience. Dr. Nitin Shetty from Tata will be presenting about vertebroplasty. So Dr. Nitin Shetty is not present personally because of some issues. But he has kind enough to send his recorded version for the conference. Anyway, he will be online. If any case of questions are there, he will be ready to answer. Thank you.
Good morning, everyone. At the outset, I would like to thank Dr. Harimanan and his organizing team for giving me an opportunity to share the experience on percutaneous vertebroplasty in multiple myeloma. I apologize for not being there in person, and I would like to thank Dr. Saikant, who has agreed to moderate the session in my absence. I would request Dr. Saikant to pause the proceedings at any time he feels if some clarification is required. I think it is perhaps the first time I have ever received an invitation wherein the duration of talk is twice the duration that would actually take for the procedure itself. Now, let's start with the definition and the simple definition of what is VCF, or a vertebral compression fracture. We call it when the vertebral reduction in vertebral height is at least 20% or 4 mm in height. And there are a few vertebral augmentation procedures which are used to treat the vertebral compression fractures. So they are named as percutaneous vertebroplasty, percutaneous kyphoplasty, and percutaneous implant techniques. So in percutaneous vertebroplasty, essentially a needle is inserted into the vertebra and strengthened by putting cement. In percutaneous kyphoplasty, which is normally done to restore the height of the vertebra, wherein initially a balloon dilatation or balloon is opened up inside the vertebra, subsequently filled with cement. Similarly, percutaneous implant techniques also is a methodology wherein the height of the vertebra is increased by placing some implants like the stents or coil, so that the and subsequently followed by injection of cement so that the vertebral height is restored. So among all these three, the experience that we have at the Tata Memorial Hospital is in percutaneous vertebroplasty, on which I would be talking more about, and that is what I have been requested to cover in this particular workshop. So it was described by Deramond in 1987 when it was used for the first time for the treatment of aggressive vertebral hemangiomas. So this is self-explanatory, that is, it's therapeutic. That is, when it is when a procedure is done, the pain is relieved. It is minimally invasive because it is just done done percutaneously without opening up the spine. And of course, it is an image guided procedure. That is, we use the help of most of the time the C-arm and occasionally the CT scan to inject what is called the cement. The cement is normally radio opaque. That's why it is very easily injected under fluoroscopy. There have been few proposed theories for regarding the mechanism of action which provides relief of pain. One of the main theory is that injecting cement brings about biomechanical stability to the spine, because of which the pain reduces. The second thing is that the cement itself, it is toxic to the tumor, and this chemical toxicity would be responsible for reduction of pain. And also the polymerization of cement, that is, when the cement hardens, it does so, it happens so by the exothermic effect, that is, there is release of heat, and this heat would essentially act on the nerve ending, which would contribute to the control of pain. So these are the various theories. Now moving on to the indication, if you see most of the guidelines, it would mention painful osteoporotic vertebral compression fracture as the most common indication for vertebroplasty, especially those which are refractory to medical treatment. The other indication being painful benign bone tumor like an aggressive hemangioma, uh, multiple myeloma or any other hematolymphoid malignancies, and also metastasis causing spinal pain or vertebral pain can also be treated by vertebroplasty. By and large, the contraindication is absolutely asymptomatic vertebral compression fracture or those VCF which are responding to medical treatment. If there is infection of the spine, that's osteomyelitis, again, is a contraindication. So is uncorrectable coagulopathy. But of all these things, I would be talking essentially about the extensive osteolysis that would be caused by multiple myeloma, for which percutaneous vertebroplasty is one of the preferred treatment to reduce pain and also to improve the quality of life. So most of you would be aware about the two trial that was published in the previous decade, where vertebroplasty was compared with the sham procedure, and it found that there is no significant difference in the elevation of pain as compared to the two arms. And hence, when it came to osteoporotic VCF, the percutaneous vertebroplasty actually fell into disrepute. However, it is a totally different scenario when it comes to the treatment of osteolysis by multiple myeloma. So in 2019, the International Myeloma Working Group, they came out with some consensus statement wherein they very clearly mentioned that if the patient is having pain from a vertebral compression fracture, and if it is evident on MRI, that would be an indication for vertebroplasty. Similarly, persistent pain, that is, the visual analog score of between 4 to 6, which again does not get resolved after conservative management of 4 weeks. That's also an indication for vertebroplasty. If a pain is significant, which is affecting the activities of daily living, it's again an indication for vertebroplasty. Even if the patient is not symptomatic, the fracture that is involved in the thoracolumbar junction, that is from T10 to L2, is a relative indication for vertebroplasty, because if there is a fracture, then it would cause significant amount of kyphosis, and this kyphosis itself would have some changes in the biomechanical stability of the spine, which can lead to chronic pain and facet joint hypertrophy. So to avoid these things, the asymptomatic reduction in vertebral height of vertebra between T10 to L2 is recommended to undergo percutaneous vertebroplasty. Similarly, asymptomatic, but if consequent or sequential erect radiographs shows loss in the height of the vertebral body height, that is done between 1 to 3 months, it becomes a relative indication again for performing vertebroplasty. Now, in coming to patient selection, at Tata Memorial Hospital, we have the multidisciplinary consensus when anytime the patient is referred for vertebroplasty. Detailed clinical history and examination is taken, and examination is done before confirming the need for vertebroplasty in these patients. Now, one of the important things as an IR person doing the procedure is to rule out that the cause of back pain is not because of degenerative spinal disease. Because even in multiple myeloma, elderly patient, it might happen that the patient has got an overlapping degenerative spinal disease. So degenerative spinalosis and radiculopathy, these have to be ruled out. This can be done by evaluating the MRI. And in case if there is a soft tissue component which is causing compression on the spinal cord, on the thecal sac, then that also would become a relatively contraindication for vertebroplasty. The patient need to be started on steroids, chemotherapy, and might require decompression if the patient has got obvious neurological symptoms. Prior to the procedure, we document the pain score, that is a visual analog score, and also the SIN score, that is a spinal instability neoplastic score. So the SIN score would essentially tell how bad the stability of the spine is. So it can be graded from 1 to 18. So anywhere between 13 to 18 is considered as an unstable spine, and which would warrant a vertebroplasty. Now, in case of multiple myeloma, it might so happen that the multiple vertebra would be involved, and many vertebra would show signal change on an MRI. So in that situation, the vertebra which has got significant pain while on palpation, or the one which elicits maximum tenderness, has to be considered to be treated first. So this is about the SIN score. These are the various components which we document while scoring the SIN score, and anything between 13 to 18 is considered as unstable, and we proceed with vertebroplasty. While coming to imaging and equipment, MRI is a must. We need to do at least a T1, T2, and stir sequences. This would essentially show the marrow being replaced by myelomatous cells. And also, T1 is a good sequence to identify fracture line. Stir sequence would show edema, and also it would suggest which is the most uh, likely vertebra that is involved or which needs to be treated. So anything that is hyperintense on stir sequence can be considered for vertebroplasty if the patient is having symptoms at that level. Now, MRI also identifies acute vertebral compression fracture, like I mentioned. It rules out infection. It also rules out the presence or absence of soft tissue in the spinal canal, which again decides whether the patient requires decompression or whether it can be taken for vertebroplasty. It rules out other possible cause for the back pain. Whenever MRI is not possible, which is a rare instance, we can do a bone scintigraphy, and CT scans once in a while might be required, especially if you are suspecting any breach in the posterior cortex. So whenever there is breach in the posterior cortex, there is a possibility that the cement might leak into the epidural space. That might be causing some complications. So we need, in those situations, a CT scan can be done to test the integrity of the posterior cerebral cortex. Sorry, posterior vertebral cortex. Now, like I mentioned, a C-arm is something that is required for injecting the cement. So always injection of cement should be under C-arm guidance, and it should be real time, so that there is no complication because of extravasation of cement in elsewhere. So the C-arm is also used to assess the site of maximum pain, and also subsequently to do the procedure. So here you can see that there is a collapse of the L3 vertebra, that is reduction in the height as compared to the other adjacent vertebra, which is quite evident. And when we elicit tenderness, if the patient does have significant pain on palpating the spinous process of L3, it again confirms that the patient would benefit from percutaneous vertebroplasty. So here, this is the fluoroscopic image verifying we assessing the tenderness at L3 level. And this is just an example of a case, a multiple myeloma patient who had back pain and was referred for vertebroplasty, but MRI showed that there is facetal hypertrophy, and which was confirmed by CT cuts taken in that region. This patient, we just did facet joint injection with lignocaine, and the patient had immediate relief, again suggesting that the cause of pain is most likely the facetal hypertrophy and arthropathy changes rather than the vertebral body involvement. So the vertebroplastic procedure was deferred in this patient. Now, what is the best time to intervene? So again, that has been a consensus statement by the International Myeloma Working Group, which stated that early intervention is always better. So the time period is between 4 to 8 weeks of vertebral compression fracture. Uh, the treating the vertebral compression fracture in this period not only improves the pain which is associated with fracture, but also it improves the clinical outcome and overall quality of life of the patient. Uh, but if the patient is at a very high risk for decubitus complications, then we do not have to wait for 48 weeks. It can be treated immediately. So now coming on to the hardware, there are different type of needles that can be used for the vertebroplasty. What we use commonly is the Murphy's 10 gauge, 11 gauge needle. This can be either a diamond tip needle. It has got a trocar and a stillet. So the stillet can be a diamond tip, or it can be a beveled tip. So the advantage of diamond tip is that it is very easy to drill the hole. However, the disadvantage is that the cement would essentially go in only one plane. There is no way you can redirect the direction of the flow of cement as compared to a bevel tip, wherein you can actually change the direction of the bevel tip and allow the cement to flow in the direction that you would want to. This is just an animation of how a vertebroplasty is performed. Essentially, we what we take is the transpedicular approach. That is, the needle we would enter from the skin, subcutaneous tissue via the muscle into the pedicle, and we would take it all the way into the anterior, into the vertebral body, and place it almost at the junction of posterior 2/3 and anterior 1/3 of the spine of the vertebra. When you see it in axial plane, this is how the needle would traverse. So it would enter the pedicle and go all the way into the vertebral body, and you position at the anterior 1/3 of the vertebral body. And subsequently, yeah, the cement is injected so that the fracture lines and the microfracture, everything is filled, and there is strengthening of that particular spine. When it comes to the thoracic level, there are two ways to approach the vertebra. Either we can go transpedicular, or we can go parapedicular. That is, we can avoid going through the pedicle. It can be, or it's also called as extrapedicular approach into the thoracic vertebra. Now coming to the cement, which is the best cement? The best is the one which is operator is familiar with. So it is recommended that you stick to one or two cement so that you understand the viscosity of the cement. You know how radiopaque it and what is the visibility of the cement on the fluoroscopy machine that you are using. And most importantly, you would know the polymerization of the cement, because depending upon the polymerization time, your speed of injection would vary, and hence it is better that you are familiar with one or two bone cement which you can keep using regularly. Normally, it is at least at Tata, we prefer to prepare the cement after positioning the needle, because you never know how long you would take to position the needle in the place where you want to be. So preparing the cement beforehand would, it polymerize the cement even before you could start injecting. So it is better to prepare the cement after positioning the needle. Again, the needle, the approach, it could be unilateral or bilateral. Sometimes if the bone is extremely osteolytic, one needle itself would suffice. The cement would spread on both the side of the vertebra. However, if the osteolysis is not very extensive, we would require bilateral transpedicular approach to fill the cement on the either side of vertebra. Now, like I mentioned, it is mandatory that injection is done under continuous fluoroscopic control, and it should be in the lateral plane. It's the beginning of the cement injection, when the cement is still in the liquid phase, is the time when there can be leakage. So we have to be extremely cautious to and keep an eye as to whether it is going anteriorly into the venous plexus or coming back into towards the epidural space. So in the beginning, we need to be more careful. And if we are seeing a movement towards the epidural space, it is better to wait for some time till it solidifies and then start injecting again so that it can spread to the other part of the vertebral body. And when the cement comes to the level of the junction of posterior one third and anterior two thirds, that is the time when we need to stop injecting the cement so that there is no externalization into the epidural space. So the post-procedure care, we need to monitor neurologically for every 15 minutes for the first hour, and then every 30 minutes for the next 2 hours. This is just to make sure that there is no epidural spillage, or in case if there is an epidural spillage, it is not causing any neurological damage because of the exothermic reaction that I mentioned at the beginning. Ideally, there is no post-procedure imaging that is required. Patient can be just kept on routine follow-up as required by his medical oncologist. We normally give antibiotic prophylaxis because these patients have got reduced immunity, and it makes sense to give antibiotic coverage for at least 5 days. Now, quickly moving on to the outcomes, in case of there are a few randomized and also retrospective studies which have shown that vertebroplasty can elevate pain that is caused by myeloma and also improve the patient's cancer disability, which actually is a significant part in the treatment of hematological malignancies. This is another paper which is published just last year, the Sardinia Spine and Stroke Congress, where they have stated that augmentation, that is vertebroplasty, is an effective treatment for painful vertebral compression fractures, and it helps in sagittal balance preservation and also and restoration. It plays an important role in the strong morbidity and mortality benefit. So even the recent consensus guidelines statement from this Congress suggests that percutaneous vertebroplasty for multiple myeloma is beneficial. Another paper again published last year, which mentions that as compared to chemotherapy alone, percutaneous vertebroplasty combined with chemotherapy can improve the quality of life by providing optimal and rapid pain relief. And this advantage of combining treatment would last at least for 6 months. There was some controversy regarding the risk of vertebral collapse in the adjacent vertebra after a vertebroplasty. However, these two papers very clearly stated that there are no risk in the incidence of new vertebral compression fractures. The most important risk factor was the osteoporosis because of the extensive osteolysis because of the neoplastic involvement itself, and the incidence of new vertebral compression fracture was similar to the natural course of the history, and it was not more post vertebroplasty. Now, the complications essentially are very minor. Some amount of cement leakage can happen. It can go up into the disc, back into the epidural space, or into the venous plexus. By and large, they would not cause any problem, especially with the better cement visibility of the cement and the fluoroscopy system. We are able to stop the injection of cement the minute we feel that it is going through the epidural space. So the leak of cement into the disc is again of not of any consequence. In fact, when it leaks to the disc, it only means that the end plate, which is quite not strong enough, is getting strengthened by the cement. Again, the risk of infection is less than 1%, and like I mentioned, there is no risk of collapse of the adjacent vertebra. At times, some patients may be allergic to bone cement, and bleeding from the puncture site or from the one of the muscular branches is one of the other known complication which can be managed by compression. Now, couple of points about percutaneous kyphoplasty or percutaneous implant technique. There is no strong evidence to recommend these two over percutaneous vertebroplasty. The only indication, or rather best indication, would be a traumatic acute vertebral compression fracture which has got a kyphotic angle of more than 50 degrees. So if there is 15 degrees, so if there is no kyphotic deformity, just a percutaneous vertebroplasty is good enough to alleviate the pain in multiple myeloma patients. Now, moving on to few of the cases. So this is a 49-year-old male who had a pre-medication pain score of 9 by 10. On medication, it was still reduced to 6 by 10. His quality of life was affected. His SIN score was 14 by 18, which suggested that unstable spine, and there was tenderness elicited at L1 level. There was no radiation of the pain. That is no radiculopathy, and there was no bowel or bladder involvement. On MRI, you can see that though multiple vertebrae are involved, there is height loss of L1 vertebra. There is not much of edema seen, but the patient did have tenderness at that level. One of the first steps that we do during vertebroplasty is profiling of the vertebra. So here the affected L1 vertebra is profiled in such a way that the pedicles, the spinous processes are in the midline, the pedicles are well seen. And what we essentially do while profiling is that we match the end plate level. We adjust this theum in such a way that the vertebral end plate is seen as one line. Here you can see that the vertebral end plates are not very clearly seen, but once profiling is done, the vertebra appears like a rectangle, pedicles opened up, and you can clearly plan how you are going to enter the vertebra. So like in any procedure, first you infiltrate you plan from where, from the skin till the vertebral body. So if you're taking a bipedicular approach, your needle would essentially terminate close to the midline. And if you draw a line backward where it would meet the approximately at the lateral end of the uh, transverse process is where you would mark on the skin, and from that point you would initially put a spinal needle and enter the pedicle in a 10 o'clock position. You would infiltrate all the way from the skin till the 10 o'clock position of the pedicle. This is on the patient is in prone position, so this would essentially be on the left side. On the right side, similarly, from the almost at the level of where the transverse process ends, from the skin down to the 2 o'clock position, you would the LP needle and infiltrate the tract. So this is just an animation to see to show how it would be. So from the skin via the 10 o'clock position, you go towards the midline, and similarly on the lateral view, you again need to profile the vertebra. On the lateral view, you can see that the margins of the vertebra is well made out. The neural foramen is opened up, and again this is the needle to infiltrate the local anesthesia. This would be the trajectory that we would take. Enter from the skin's subcutaneous tissue via the muscle, enter the pedicle, and go to the anterior one third of the vertebra. So this is when we're taking a bipedicular approach, this is how we would go. We would pretty much stay close to the midline. But if we are taking an unipedicular approach, we can go a slightly deeper, cross the midline, and then reach the other side of the vertebra. As we have done in this case, you can see that it has gone transpedicular, reached the anterior one third of the vertebra here. When we see it on the AP view, we have crossed the midline, and subsequently we have started injecting the cement. Again, like I mentioned, we need to monitor it real time on lateral view. The cement is injected, and intermittently we see the cement distribution in the AP view, just to make sure that it is not getting extravasated into the paravertebral tissues. So once we are convinced that the other contralateral hemivertebra is getting filled, then slowly we can withdraw the needle. As we withdraw the needle, continue to inject the cement, and even the ipsilateral side also gets filled. So this is an example how by unipedicular approach we are able to put cement on both sides of the vertebra. But at times it is possible to do via any particular approach, but most of the time we do end up doing a bipedicular approach. As in this patient, a 49-year-old female who had relapsed multiple myeloma, a sin score of 10 by 18, that is not an unstable spine, but then the pain score is 8 by 10, not relieved on medication. Again, tenderness is at L1 level, and if you see the vertebra, pretty much all the you can see that the marrow at many vertebrae have replaced. There is a reduction in the height of L1 vertebra in the anterior aspect. You can see it here. There is no radiculopathy, and bowel and bladder involvement is not there. Again, like I told, start just lateral to the transverse process from the skin. You follow the trajectory. Initially, put the local anesthesia, infiltrate all from the skin till the pedicle, 10 o'clock position on the left side, and 2 o'clock position for the right pedicle. Again, I'm saying this as a left side because the patient is in prone position. So once you have infiltrated the entire tract, use your the bone biopsy needle, and this the stepwise you can see here we are entering the pedicle here, partially entered, and subsequently we go deeper and then reach the position of choice. So one of the things which is very important that I need to mention is uh, till we cross the pedicle and enter the vertebral body, we have to be extremely cautious that we do not breach the pedicle. So till we cross the pedicle, we have to monitor in both the planes. So as we proceed deeper and deeper, we need to make sure that see we see the needle in the AP position also, and till we cross the pedicle and go inside, the needle should always stay inside the medial rim of the pedicle. So if you are entering from the 10 o'clock side, till you cross the pedicle and enter the vertebral body, you have to remain inside this pedicle itself. So once you are in the vertebral body, then you can the needle can be seen outside the medial wall of the pedicle. So this is something very important that we need to remember. So here, once it was positioned, then subsequently another needle was inserted from the contralateral side, and then this was exactly overlapping. So we gave intentionally a mild tilt so that we could see the cement being injected. And after one side was injected, the needle was removed, and then we have filled the other side. And this here you can see that the entire vertebra is filled with cement. And what you see here is actually the cement entering into the venous plexus. Again, if we stop here, that would not cause any problem to the patient, because here you can see this is into the venous plexus. But if you continue to inject, this would essentially go into the IVC, and if it breaks off, it can fly off into the pulmonary circulation, causing pulmonary embolism. Otherwise, by and large, venous extravasation into the venous plexus would not cause any harm to the patient. So this patient had immediate relief, and the pain score reduced from 8 to 2, and the patient was also off analgesic after 3 days, and there was improvement in the mobility also. Now, can we treat more than one vertebra? Yes. Even the consensus guidelines mentions that you can treat three vertebra in one sitting. This is a 63-year-old patient with a pain score of 8 by 10 sin score. Again, just on the side of unstable spine. Tenderness at two levels, L1 and L3. Here you can see that there is reduction in the height of vertebra of L1 and L3. Essentially bedridden, and that again becomes an indication for vertebroplasty. Um, Here again we treated both the L1 and L3 in the same setting, and we can you can see that in the L3 vertebra, which was more significantly involved, there has been some seepage of cement into the disc space. Again, it is not of much concern. But the beauty of the procedure is the pain score dramatically came down to 2, and the very next day the patient was able to stand, who was essentially bedridden till this point of time. Another patient who was bedridden because of multiple vertebral involvement. You can see the sin score is 14 by 18, significant spinal instability. At the time of initial presentation, D9 and D12 level were involved. Here you can see, and also you can see L3, but though there is edema on palpation, D9 and D12 were the vertebra which were involved. So we went ahead and performed the D9 vertebroplasty initially, and D12 also in the same setting. So the patient had good pain relief, and subsequently in the follow-up visits, the patient started having tenderness in the other areas. So we treated again subsequently the L3 vertebra, the L4 vertebra, and this is when the patient had come for the treatment of L2. So essentially, the patient had D9 and D12 and L2, 3, 4, 5 of the vertebrae having treated, and the patient had a good quality of life because the patient was immediately treated with vertebroplasty whenever developed pain and restricted mobility. Now these have been example for the lower thoracic and the lumbar vertebra. Similarly, we can also treat the vertebra higher up, that is the mid-thoracic or the and also the cervical vertebrae, but the indications are not as common as that in the thoracolumbar region. Here we have treated D7 vertebra. Again, the patient is not having much pain, even though there is some hyperintensity and collapse of the vertebra. But the relatives complain that there is progressive stooping of the patient, especially when the patient starts walking. Considering this reduction in the height and stooping gait, we decided to do vertebroplasty of this vertebra. That is a D7. Like in the lumbar level or the lower thoracic, we first profile it. It's quite difficult at the mid thoracic level because of the overlapping ribs and the scapula. You can see the scapula over here. At times, we might not see the pedicle and might require CT scan for the initial placement of the needle, but in this case, we could manage under fluoroscopy itself. So once the needle is positioned, again bipedicular approach was taken, and very carefully under a continuous fluoroscopy cement was injected, and this is the final picture of the D7 vertebroplasty. So to conclude, percutaneous vertebroplasty is safe and it is effective procedure, especially in case of multiple myeloma patients. It provides instant pain relief, and it also provides biomechanical stabilization of the spine. It improves the quality of life, and hence we do not have to wait for a long time to do percutaneous vertebroplasty if the patient is symptomatic. So I would like to thank the adult hematolymphoid DMG who have been quite generous enough to refer the patients for percutaneous vertebroplasty whenever indicated. And also I would like to thank my mentors and my colleagues who have been quite supportive of the procedure and who have helped to develop the procedure in the department that is ultimately done into benefit for those patients who are suffering from pain because of the multiple myeloma in their spine. Thank you very much, and I again apologize for not being there in person, and I would like to thank Hari Menon sir again for giving me an opportunity to share the experience. Thank you. Dr. Saikant, I would be by my phone. If there are any queries, please feel free to call me or just text me the queries. I will answer the queries. Thank you.
And answer session for panel discussion. During panel discussion, we'll go for the next talk.
Uh, it gives me great pleasure to invite Dr. Shanmuga Sundaram, I would say the pioneer now in PET MRI, the only institute which has both the modalities combined to evaluate multiple myeloma. I hope after this talk we'll have most of our doubts cleared. And sir is a clinical professor and the head of Department of Nuclear Medicine and Molecular Imaging at Amrita Institute of Medical Sciences. Welcome, sir.
Thank you, chairpersons. Good morning, everyone. At the outset, I like to thank the organizers once again for giving me an opportunity to be part of this wonderfully arranged workshop. I am really happy and privileged to be discussing this highly interesting topic, PET MRI in multiple myeloma, our experience with this august audience. So in the next 25 minutes or so, we shall be discussing the relevance of PET imaging, the radiopharmaceutical FDG, how it is relevant and useful, what is the present status of PET imaging in multiple myeloma, the next component of PET MRI, the MRI imaging. We have heard a lot from the expert in MRI. We shall be following and we shall be discussing the interpretation criteria, the advantages of MR imaging in multiple myeloma, the present role of MRI in multiple myeloma. Finally, we shall be discussing the combined hybrid imaging modality, the PET MRI, the principle, the technical aspects, and possibly what is the potential advantages of this PET MRI in the multiple myeloma diagnosis and its follow-up. So I have the privilege of working in this institute where I have both imaging modalities. So we have a 16 slice PET CT and also the PET MRI. Always PET MRI is a 3 Tesla PET MRI, which is ideal for small organ imaging and small field of view imaging, but this is being used as a whole body imaging technique also. From the image itself, you can easily make out that the bore is always smaller than the PET CT. So the field of view is around 45 centimeter. So patient compliance is something which we need to be always be aware of that, and the timing of the imaging. The timing of the imaging is somewhere around 1 hour 10 minutes to 1 hour 20 minutes. So patient compliance and less throughput. These two are to be kept in our mind when we do an imaging in a hybrid imaging technique like a whole body PET MRI. So we know very well that FDG is the radiopharmaceutical of choice for the oncology imaging. There is some specific point I like to highlight. One is the overexpression of hexokinase 2 in myeloma cells. Thereby we can actually expect a higher FDG uptake in the myelomatous cells when compared to normal cells, and we know that once the fluorodeoxyglucose gets integrated into the Krebs cycle, it is retained in the cell and it doesn't go through the normal glucose metabolism. That is the basis of using FDG as the imaging radiopharmaceutical of choice for the PET imaging. So let us discuss what could be the potential indications of FDG PET imaging in multiple myeloma. One is initial evaluation. It can be used for prognostication. Obviously, this is an imaging modality of choice for therapy response, and it is a better imaging modality when compared to a low dose CT or a CT imaging alone. So when we do a FDG PET imaging, there should be an interpretation criteria. All hotspots are not going to be the disease. So how to interpret and how to approach the images in a suspected myeloma case. The first one is the SUV max. I am quoting from the literature. The accuracy and the specificity improves if you have an SUV max of more than 4.2, 3.5 to 4.2, and diffuse bone marrow FDG uptake. Diffuse heterogeneous bone marrow FDG uptake is highly specific for the myelomatous involvement in the bone marrow, and you can also look for focal on diffuse uptake. We shall be seeing some examples to highlight these interpretation criteria. And I personally feel the FDG PET imaging is indispensable for the extramedullary disease assessment. Why should we be looking for extramedullary disease assessment? Obviously, there is clear-cut literature that up to 14% of patients can have extramedullary disease at presentation, and up to 18 to 20% of patients can develop extramedullary disease during the disease progression. And the extramedullary disease can be in any place: the soft tissue, pleura, liver, the lymph nodes, spleen, and also paravertebral areas. So that highlights the need for a whole body imaging, and that's where the FDG PET imaging fits in. So there are some specific criteria that are being used, although we don't routinely use it, but we have found the impetus criteria, that is the Italian myeloma criteria for PET use, which takes into consideration the involvement of bone marrow, and that can be scored as Dewey's criteria, like Dewey's criteria. Then you look forward for the abnormal uptakes in the focal areas and also in the myelomatous extramedullary sites. Taking these things into consideration, we can use these following things for the prognostication. Number one, the number of focal lesions. If you are picking up more than 3 focal lesions in a FDG PET, the prognosis is going to be significantly worse when compared to less than 3 focal lesions. The presence or absence of extramedullary disease obviously is going to make a lot of difference in the prognostication of the patient. We have seen the importance of SUV max more than 4.2, and there are now new quantitative criteria. Apart from dealing only with SUV max, we can actually quantitate the overall disease quantity in the form of metabolic tumor volume and total lesion glycolysis. So these things also add into the prognostication factors, and obviously for the disease detection of extramedullary disease, the FDG PET is preferred. So what does the literature say? If you have to start an imaging procedure when you are having the choice of doing an FDG PET and a whole body MRI, the literature says you start with the patient of suspected multiple myeloma with whole body FDG PET. If it is positive, obviously we are going to prognosticate the patient and stage the patient. But in case if it is negative or if it is inconclusive, you can go for an MRI. When we do an MRI, obviously we depend and we interpret mainly the diffusion weighted images, and when you compare the efficacy of diffusion weighted images with the FDG PET, there are conflicting reports in the literature. Almost there are 50-50% reports for and against these individual modalities, that is the diffusion weighted imaging whole body and FDG PET-CT whole body. So how the whole body FDG PET performs when you have a chemotherapy response, and how to interpret the chemotherapy response. The disappearance of the focal lesion, what we mean by that is the complete disappearance of the FDG uptake. Obviously the metabolically quiescence of the disease is highlighted, so this is going to be a very good prognosis. If there is a reduction in the SUV max at least by 25%, then you can say that patient is responding. If there is more than 50% reduction in the SUV, it is a partial response. There are some interesting studies in the literature which highlights the relevance and role of FDG PET over MRI. You can see that as high as 32% of patients who have negative lesions are being shown in an FDG PET. In the same group of patients, only 3% of patients are being shown as response positive patients. So possibly we can say for therapy response, FDG PET should be preferred. Also in patients who are going to be taken up for autologous stem cell therapy pre and post, in both these situations FDG PET performs well. So what should be the consensus when to use the FDG PET? FDG PET is recommended over MRI in therapy response, and it has definitely it scores over the whole body MRI in the both pre and post autologous stem cell therapy procedure criteria. So, but in practice what happens? It all depends upon the availability and the confidence the clinician has on the imaging people. So both are being used interchangeably. Although ideally FDG PET is considered to be a good and better imaging modality for chemotherapy response. So having seen the advantages of PET in our day-to-day practice of imaging of multiple myeloma, does MR lags behind? Not really so. MR has its own positive values, and it is the imaging of choice for bone marrow evaluation, and it is obviously it is being routinely recommended by the International Myeloma Working Group, and that's where the diffusion weighted images comes into play. Obviously the MyRATS criteria are normally used for therapy response, although it is not routinely being practiced. We have heard and we have understood the importance of the T1 imaging in the normal MR interpretation of multiple myelomatous lesions. We look forward for the hypointense lesions, and obviously the size is most of the time, or we say it is a positive lesion if it is more than 5 millimeter, and our confidence level increases if you have this combination, that is T1 hypointense and still bright focal lesions in the T2. So what are the patterns? We have, again, I'm just going through what we have already learned: the focal, the diffuse, focal on diffuse, and salt and pepper appearances. So all these four are to be looked for in a whole body MR imaging. So how MR whole body imaging it performs when it comes into the staging and prognosis? If you have more than 7 lesions, it is an adverse prognostic marker. Again, it shows the sensitivity of whole body MRI, because you say more than 3 in FDG PET, but you say more than 7 in the whole body MRI. Obviously it has more sensitivity. So we have learnt the fact that it is the imaging modality of choice for bone marrow evaluation. But I have some reservations to say the MR for the therapy response, because first of all the overall specificity is less, and you have to do a dynamic contrast enhancement studies, then only you will be able to confidently say that there is therapy response. So what are the interpretation criteria for bone marrow lesions? We can use the high ADC values, and this has been established in the literature. You can look forward for these B values. Normally for the increased intensity in both low and high B value scans, and these are some of the values which we normally can be followed in our day-to-day practice. So the focal bone marrow lesions have a high B value for the ADCs. So now, having understood the positives and negatives of whole body FDG PET and FDG and the MRI imaging, we can always think, if we have a hybrid imaging modality in a integrated hardware and software based, then should be the one-stop shop imaging for the multiple myeloma. And that's what is being provided by the wholesome PET MRI information. This is the amalgamation of the functional and molecular information, obviously provided by the FDG PET, with anatomical precision due to exquisite anatomical details provided by the MRI. So this is a classical example where the real utility of whole body FDG PET MRI hybrid imaging can be highlighted, that is with multiple myeloma. So we obviously know the various MRI advantages, and there is one point I like to highlight at this point is there is absolutely no compromise as far as the technical aspects of the whole body FDG PET and whole body MRI when you do together in a hybrid imaging modality. So the quality and the technical aspects of the images are always maintained in this present hybrid imaging technique. So as again we have learnt, the optimal imaging protocol is definitely in place. Obviously we need to know the fact that it takes more time. So the Dixon images, these Dixon attenuation correction images are a must as far as whole body PET MRI is concerned, because that is the backbone of attenuation correction of FDG PET images using the MR sequences. And obviously we also do a haste whole body coronal, and as we have already heard, the importance of the T1 and also T2 stir image, and we always focus on the whole spine also. We have found there is a good consistency of the SUV max value, whether it is a PET CT or a PET MRI, and this should be the right imaging combination for initial evaluation, prognosis and therapy response. So obviously this should be the imaging modality of choice when a known diagnosis of myeloma is there. The clinician is going to start the patient on therapy. So all these 3 points can be highlighted. And in the literature and in our own limited experience, we have found there is a good correlation between the SUV max and the ADC value, both for the local and that is the focal lesions and also for the diffuse bone marrow lesions. So having gone through the positives, negatives and the literature review, let us see some of our own images as examples. Some of the points I like to highlight. This is a whole body FDG PET CT. This is a very good imaging modality when you have mainly the skeletal lesions, that also highly undifferentiated lesions. You can see very high SUVs and obvious osteolytic lesions. So this is where both low dose CT, the CT whole body and also FDG PET CT will definitely be more than enough, and FDG PET CT should be the imaging modality of choice because it can also predict the prognostication, and also it should be the baseline study for therapy response. But when you have some diffuse disease, you can see the exquisite quality of image of the FDG PET MRI also, because it is acquired for a longer time with time of flight and also with the better crystals. So the image quality is definitely better, and this is what I want to highlight, the heterogeneity of the FDG uptake both in the diffuse lesions in the bone marrow and also the focal lesions in the skeletal system. Apart from that, you can also see the perimedullary lesions. Basically the soft tissue lesions just abutting the skeletal lesions, and the heterogeneity of the SUV can also predict how these lesions are going to respond to the various types of chemotherapies. Again, an interesting case, only the extramedullary disease. One is in the intestinal loops, ileal loops. You can see a very high FDG uptake. On the other hand, the original lesion, the nasal lesion, which was presenting as a nasal swelling, and during the surgery the biopsy shows it as to be a myelomatous lesion, shows very less uptake. Again, the heterogeneity is highlighted, and most important, by a one-stop shop of whole body imaging with FDG PET and MRI, we are able to be more confident about the presence or absence of diffuse marrow disease and also the extramedullary disease. So as it is highlighted, the complications of the myelomatous lesions in the spine, like spinal cord compression, obviously MR should be the imaging modality, and the impact of SUV in prognosis has been highlighted in this image. You can see the highly undifferentiated myelomatous lesions showing very high FDG uptake, and in one go we are able to show all these lesions. So therapy response. So this is a patient presenting again with bone marrow lesions and also with the iotocaval and para-aortic lymph nodes. Complete disappearance of the iotocaval lymph nodes, both anatomically and also metabolically. So both can be shown in one imaging modality. So this is the last case I like to highlight, where we have a longer follow-up of this patient. Patient is presenting in 21 with a single lesion in the left femur, treated with chemotherapy, responding well for that lesion, but there is further progression of the disease in the ribs, and patient further being treated with the second line of chemotherapy, but there is no response. You can see when compared to the June 22, December 22 shows further progression of the lesion. So therapy response and prognostication is highlighted in this. So there are potential other radiopharmaceuticals like choline, methionine, and alpha methyl tyrosine. So some of them are labeled with carbon 11, which is no more or not available in India, but there are specific radiopharmaceuticals which can be used in potentially can be used in future. One is fluorine labeled choline. So of course right now we don't have much of experience in that. So how to approach this so-called controversy or so-called choice of FDG PET whole body and whole body MRI? So right now the whole body PET and whole body MRI is recommended by NCCN, but the working group recommends only MRI. So my humble opinion is there is no ideal wholesome imaging modality. You have to look forward for specific points. You want to assess the bone marrow, go for the MRI, and the extramedullary disease, probably FDG PET is better. For prognostication and therapy response, FDG PET will be better, and for very early diseases, and if you want to follow up these patients, then like smoldering myeloma and MGUS, whole body MR should be the imaging modality of choice. And for initial evaluation, because both FDG PET and MRI is faring better, and because it is available with us, we sincerely believe a combination of whole body FDG PET MR can be the imaging modality of choice, provided it is available. So what should be our take home message? It is possible. First one is the whole body FDG PET MRI imaging modality is possible. The protocols have been standardized, and with the patient cooperation it is possible. And probably this is an ideal platform for future applications like artificial intelligence. Right now the imaging modalities of the FDG is going to stay back until we identify a better radiopharmaceutical. And when it comes to MRI, we always look forward for DWI and quantitative parameters. When both combined together, possibly will be the imaging modality of choice. Thank you very much for your patient hearing.
Just want to ask you one question. So you are having both the modalities. Which one is your favorite?
Both the modalities means you are talking about
Both
FDG, PET,
CT as well as MRI.
PET MRI.
PET MRI.
PET
Yes.
MRI.
See, first of all, the choice is decided by the clinician. Most of the time, on a serious note, cost also is an important factor. In my institute, the difference of a whole body MRI and whole body PET CT is only 10,000 rupees. So when there is only a difference of 10,000 rupees, many times, especially for initial evaluation with the clinical features where it strongly predicts that he will be going for a chemotherapy, they prefer whole body FTG PET MRI. On the other hand, if there is a chance discovery and obvious lytic lesions in a CT, they go for a whole body FTG PET CT. But personally, if you ask me, if there is a patient cooperation, I will go for a whole body FTG PET MRI because it is available with me. But I have, having highlighted all the positives, I also highlighted negatives also.
So MRI will take lot of time. Most of these patients.
Yes, see the imaging of the FDG PET, I take 4 bed positions, and if I take 5 minutes image, normally in a whole body PET CT, each bed position only 1 or 2 minutes imaging I am doing. So here 4 bed positions, 5 minutes if I am going to get, more than enough for me to interpret, 20 minutes. But obviously my MR colleagues, he wants lot of images. It is not that he or she wants. Obviously you need to look forward. For example, DWI of one single area is not going to be of help. We have to take the whole body. So obviously that takes a minimum of 40 minutes to 50 minutes.
How will you counteract that? Whether you will take any anesthetic help or
yes, see, most of the time the patient cooperation, that's where I told, the initial evaluations becomes easier. But if the patient is already having pathological fractures and the hardwares, that also is an important issue. So in those type of patients, we take the help of the anesthetist also. And we have a in-house and permanent anesthetist posted for MRI, PET CT and PET MRI. So we try to manage it, but definitely that's a practical aspect.
Thank you.
Sir, so what is your take on Pentixafor, FAPI and other zirconium daratumab?
I think there is definitely going to be a lot of potential applications of Pentixafor and the FAPI. We have done some of the cases. I thought let me not complicate too much. Most of us we are using FDG PET, and definitely there will be a better sensitivity, I feel. But some of the literature what I have seen with FAPI is equal. They say it is equal. But I think we need to have larger number of patients. Right now, I don't have experience to confidently say that it's going to score over. But right now, yes, FDG is good enough. Clinicians believe a lot on FDG rather than many other things, especially on the therapy response side.
Pentixafor have you done, sir?
I have not done too many, probably 2-3 patients. But FAPI, yes, 10 patients I have completed.
Can I have one question? Yes, sir. Please.
Yes. See, if there is a suspicion of smoldering myeloma and if the patient comes for a whole body FDG PET MRI, yes, if you have to diagnose that, there is no other option, DWI. It takes more time, but it has to be done. Because in our institute, we have 2 1.5s and 1 3 MR, 3 Teslas. So 3 MRIs are there. Yes. Definitely we have picked up.
Even the literature says that the diffusion is the ideal method, and it detects nearly 20 to 30% numbers of the myeloma lesion in comparison to the T1. So that's why nowadays people say that diffusion is must. Diffusion is the must.
I think we will have a panel discussion where we will get so many questions.
Yes.
Okay.
Thank you very much.
So the main agenda of this workshop is to formulate consensus how to go about a disease like multiple myeloma, when a patient comes to us, how to go about it, which modality is better, and how to formulate a stepwise approach in diagnosis and management of this disease. So this we have to do with a good panel discussion. So for panel discussion, I like to invite Dr. Nagaraj KR, is Senior Consultant Radiologist, Precision Teleradiology Solutions and Domis PET CT Center. We invite you for the panel discussion, sir. And Dr. Sadasivudu Gundeti, Professor and Head, Department of Medical Oncology, Nizam's Institute of Medical Sciences, Hyderabad, Telangana, India. And we like to invite Dr. Murali Nadik, Chief Consultant and CEO, NewMed Diagnostics, Bengaluru. We like to invite the speakers also for the panel discussion. Dr. G. Ram Mohan Reddy, Dr. Sunita Palasamudram, Dr. Mahesh Prakash, and Dr. P. Shanmuga Sundaram. Dr. Chandana will be taking over and showing few cases, and we will like to have your expert opinion and how to go about it.
Uh, Thank you, Sarkant. Very good afternoon to all of you. We've heard in this talks, very informative talks about MRI, whole body CT, and PET MRI. Now, few cases and how clinically it makes sense. A lot of theory is fine, but practically how to approach it and how do we treat these patients. So, few cases here, and I would pose the question to the panelists to come to so that we can come to some consensus on the imaging guidelines to take it forward after this conference. Case 1 is a 48-year-old female patient presented with a history of a low back pain since 2 months. She also had a history of trauma on the left foot. X-ray showed a fracture of the 5th metatarsal bone. A lumbosacral spine was asked, and that showed an anterior wedging and a hairline undisciplined fracture of L4 vertebra. Her serum creatinine was 0.9 milligrams per deciliter, HB was 7.5, and calcium was 10.5 milligrams per deciliter. This was her X-rays. What next? I would first pose the question for blood investigation to Dr. Sadashivudu.
So first always in the whenever we think of multiple myeloma, the first thing what we will ask is hemogram. Hemogram means I think WBC count, hemoglobin, platelet. At the same time, some people they'll also ask ESR. So there's a blood investigation. Next one is a hemogram. Next one will go to this kidney function test. Creatinine. Again, these are one some of the areas we'll known as end organ damage. In the sense, in the hemogram we'll see low hemoglobin. That's a 1 point. And this kidney function test, the creatinine also will see that when the creatinine any elevation, we'll calculate the GFR according to that. And third one, liver function test. The liver function test also will give us some clue that what you said is correct. The morning I think we had a discussion. The alkaline phosphatase is normal if you think of multiple myeloma. The alkaline phosphatase is elevated. Again, we'll think of something secondaries or either other than the bone disease, other than multiple myeloma. And one more thing, one point we may get is the total protein also. Total protein is elevated, albumin is low. This albumin and total protein dissociation. Definitely we can think of something, it could be the multiple myeloma. So, hemogram, low hemoglobin and high ESR, kidney function test, creatinine elevation, and third point again, blood calcium levels also. You mentioned calcium levels. Again, we have to see the corrected calcium levels. Just 10.5 doesn't mean anything. Again, you have to see the albumin and we have to calculate according to that. And based on these investigations, the liver function test. So based on these all factors, to a conclusion that it could be a multiple myeloma or non-multiple myeloma. So we'll do the blood investigations at that point of time. Based on this, again we'll go for electrophoresis and the test.
So in this patient, you wouldn't ask for an electrophoresis in the first go. After you get those investigations, then only you're going to ask.
Because as a teacher, as a clinician, I think we have to just don't jump into all the conclusions. This could be multiple myeloma immediately in the first step itself. So we'll give us one clue one by one. Then definitely we'll ask for something the M spike. Again, we don't want to ask for immunofixation of M spike. There's any, there's I mentioned protein. So total protein is elevated, albumin is low. There is a gamma fraction, globin fraction elevated. Definitely it's a multiple myeloma with normal albumin phosphatase. Then we'll ask for M spike. It's electrophoresis. If M spike is positive, then we can think of some immunofixation. What type of this abnormality it is. So next investigation.
Sure, sir. Thank you. So now I'll go to Dr. Nagraj. Which radiological investigation would you prefer, sir?
Looking at the X-ray, there is some fractures and there was a history of metatarsal fracture also. So we could be dealing with keeping things open. It can be a osteopenic fracture, or it could be a metastatic disease or a myeloma. All three will come into the mind. So we would like to do an MRI, see what fractures, types of fractures are these, whether these are bone marrow infiltration with pathologic fracture versus osteopenic fracture. We can differentiate those. So you can also get to clue how much, if there is marrow infiltration, what is the type of marrow infiltration, and we can also localize to an extent any paravertebral soft tissue disease or an extramedullary disease. So an MRI would be ideal in this scenario, keeping looking at the parameters and the
Sir, the question here is since the patient has come with a low back pain and a fracture, and as Dr. Sunita already mentioned, many patients who go for an investigation for low back pain, they don't do all the sequences required for multiple myeloma workup. So do you specifically ask those in this point of time?
No, as a radiologist, I would not ask for any myeloma workup or anything. It's not my purview. I would recommend an MRI, and we would see what is the type of the lesions in this particular patient.
Okay. So next I go to Nadik sir. Sir, do you think before doing MRI, is there a role for a PET scan here?
No, I think I will ask for detailed that investigation report, and only then I will decide. If even as a radiologist or as a nuclear medicine physician, I think we have to think clinically first and then ask for investigation. So, and if the money is same for everybody, actually, whether it is my money or the patient's money, I don't want unnecessary investigation. So I will always go back to the clinician and ask him, what do you think, sir, whether it is in case of myelomatous or malignancy line or non-malignancy line. If it is myeloma or malignancy, metastatic line, then I will say PET CT is better. If it is not, then I think you can go for bone profile, and even PTH I think we have to ask, and maybe systemic scan or like that.
Thank you, sir. Actually, this patient underwent all the blood investigation and there was a high suspicion of myeloma. So she underwent the CT scan. And CT scan revealed multiple lytic lesions in the vertebra and a compression fracture. Also, along with that, what happened? Multiple rib regions with soft tissue density, associated soft tissue density was noted. And incidentally, they picked up, it's not very clear here, but enhancing lesion in the region of the anus. So I'll now pose the question to Dr. Mahesh. So what next?
Yes, so actually the important point to remember for all the people, whether the clinicians or the radiologist or anybody, the important thing, like, are we doing the investigation just to confirm some diagnosis, or are we doing just making some differential diagnosis? Like if you're thinking, like, probably many things, like even the per clinical point of view, are we very sure about dealing with multiple myeloma, or there can be so many things, like particularly the metastasis, they can mimic the multiple myeloma in radiological way also. So that is the point. So that's why, like, if I like see this here, like there is a lesion and the anal canal here, and apart from the, we are very sure these are all multiplitic lesion, they are likely a metastatic lesion. So are we dealing the soft tissue lesion in the anal canal is actually the part of myeloma, soft tissue myeloma, which we call the extramedullary, the myeloma component, or it is a malignant primary malignancy in the anal canal, and there are a lot of the metastasis there. So that's why always, as I said, that always the important for the clinical point of view, like everything fits, like the clinically we're fitting the myeloma, and the CT shows these all findings, these all can be considered as a part of the myeloma. But if the other thing like myeloma, that's why, like, for considering the, even for the myeloma, there's a fixed the things like the crab criteria and a lot of the clonal, and because the clinicians here, they know about the what are the things they're suspecting the myeloma. So if you are, those are not fitting in that criteria, then if I am not the clinician not thinking of myeloma, then I will put it the malignant lesion of anal canal and the metastasis. Obviously, and the other points are favoring the multiple myeloma, clinically is fitting the myeloma. The point, all the crab criteria, the calcium and other things, the clonal cells and everything, lot of others. I am not sure about all the component, but the clinician knows about it. Then they have to think. So that's why we have to keep it openly. We have to keep things an open mind that this could be a malignant lesion in anal canal with metastasis, or it can be, everything can be myeloma.
Thank you, sir. Radha Mohan,
Just
sir.
one point. The thickening in anal canal can be more frequently, it is more of an inflammatory pathology, and a clinician, if the patient has specific symptoms, the clinicians would have definitely done a clinical examination in that area, because these are very easily picked up clinically. So we are still clueless whether this is myeloma or a metastasis. So
sure, sir. Sir, is there a role of a PET scan?
After seeing this, definitely we will request clinician to have a clinical examination of the anal canal first. If they are suspecting like a malignant kind of condition, definitely we can go for PET CT, or we can go for a biopsy, prove it if it is a malignant. Keeping in the mind the response assessment in the future, we can ask for a PET CT, and we have to think of dual pathology also in the background.
Shanmugasundaram, sir, do you think clinical examination, I agree it is most important, but do you think PET MRI would have changed the management in this patient?
No, actually, as far as the use of PET MRI, it's we have never tried to replace the PET CT with PET MRI. Obviously, it's not going to logistically and throughput wise, it's not going to work out. So obviously, the PET MRI is mainly reserved for some specific areas. As this may not be relevant to this group, but obviously it is being used mainly in the prostate, a small area where the surgical details are very important. The early gynec cancers, these are some of the common indications. Or we go for a area like musculoskeletal, especially the sarcomatous changes, where again the surgical details, the anatomical details may help, or diffuse infiltrative disorders like myeloma. So unless otherwise there is a high clinical suspicion of a myeloma in this patient, I may not have changed this patient from a possible PET CT to a PET MRI imaging. So I will definitely agree that more than enough will be a PET CT whole body imaging, and I may not have considered PET MRI for this. From a surgical gastroenterology point of view, majority of the time PET MRI is indicated in the early HCCs and cholangiocarcinomas infiltrative type. So being a intestinal lesions, most of the time they also prefer the CT rather than an MRI. And I have already highlighted 3 Tesla is not meant for the larger areas, especially like abdomen. It's for closed compartment. So ideally PET CT is more better.
Yes, sir. This patient underwent a PET scan, but
hello, yeah, madam. I think you asked me only the blood questions, only blood investigations. Yeah.
Investigation you have asked?
For example, what sir said is, for example, to differentiate between a multiple myeloma and skeletal metastasis, I think the common investigation is PET-CT. So nowadays, I think what I mentioned is most of the centers they have the PET-CT. Even if you are, for example, if I suspect something secondaries or bone secondaries, we have to ask the whole body, some the CECT, chest, abdomen, pelvis, everything. Instead of that, now we'll get a one modality, the PET-CT. We'll get the PET-CT also nowadays they are giving the contrast also. So we like the single test, we are able to get the whole body with the functional as well as anatomical imaging. So PET-CT is the next investigation of my choice. And apart from this, your blood investigations.
This is as soon as you have seen those blood investigations.
Yes.
With the back pain and other blood.
But again, clinical examination is there. I think we are discussing of this part. No, always clinical examination. But along with the clinical examination, I mentioned one pathological, biochemical, and immunological. All three departments will take into consideration along with our clinical examination. Then only we'll go to the next step. Based on one test, we never do any investigation. Again, sir said, as a clinician, we always, whether you are doing the test to confirm your diagnosis, confirm a clinical diagnosis, or for any staging workup. So for that sake, I think we should be very judiciously, we use our techniques to confirm our diagnosis, to stage disease, but ultimate clinical examination is ultimate. But here is a different, sir, you want to say something?
Yeah, I just want to say a simple investigation which can tell you or give a clue is looking at the albumin globulin ratio.
Simple.
So look at the total proteins, look at the albumin and globulin. You know, electrophoresis may take 3-4 days of time before you get the report. But if the patient is sick and you want to be, sure whether it is going towards myeloma or any other malignancy, then if altered albumin globulin ratio is likely to be myeloma.
Then we'll plan for bone marrow examination. Yes, ma'am.
What is the specificity rate, sir, for this albumin globulin?
So specificity, I would say around 65 to 70%.
One of the point I disagree with one of the point that the PET-CT can differentiate multiple myeloma versus metastasis. Actually, the PET-CT is not done to differentiate with the metastasis and multiple myeloma. It will not be able to. So that's why the clinical parameter, biochemical parameters, they will tell you. And the PET-CT is done to detect the lesions, not to differentiate metastasis versus multiple myeloma. This is the part of investigation to detect the lesions, where actually the lesions are there. It's not to differentiate between metastasis versus myeloma.
So I think the point is that maybe wording may be different. Ultimately, the PET-CT will give us extra skeletal lesions also. For example, extramedullary also. For example, you suspect something breast cancer, female patient, some breast or something, any other malignancy. In the PET-CT, you will see that lesion, no? Yeah. So with that, there is an advantage of PET-CT. I am saying not to differentiate between these two. Ultimately, all these modalities will take into consideration before we start. But in this case, again, by discussing that one, once you have seen something perianal, some anal region or perianal, this one is
Perianal.
Perianal. So definitely, again, we have to think of we have to first evaluate. Once we see some abnormality, again, we have to concentrate on that issue now. So clinical examination, then you have to go for something like proctoscopy or sigmoidoscopy. Whether there is any lesion in that one, you have to do the biopsy. Even though there is a multiple myeloma, again, we have to prove this. This is also an extramedullary something. You have to prove for that, again, you have to do the biopsy.
Yes, sir.
Yeah.
Actually, this patient underwent a PET scan, and unfortunately, it was a FAPI PET scan, which again gave very mixed lesions. And the anal lesion also showed an uptake, but the bone lesion, some of the bone lesions missed it, some of the bone lesions picked it up. So, however, clinical examination and scopy revealed it was actually hemorrhoids. Yeah.
So that's what I said. All extramedullary diseases, we have to confirm with the biopsy, then only can say it's myeloma or something like plasmacytoma or non-plasmacytoma.
Yeah.
All criteria comes also.
Yes, but especially this lesion, this perianal lesion, no, for that we should know, no?
No, not perianal. If no perianal region, nothing. You are not finding only the vertebral bone lesion, anything you found, and your biochemical, all the markers are showing towards myeloma also. You need a tissue biopsy, right, sir?
Tissue means we have the strict tissue means bone marrow examination.
Bone marrow only. That's what.
Bone marrow. There's more than 10% clonal plasma cells. So there are strict guidelines are there to diagnose the multiple myeloma.
One point I think, another point I want to highlight that there is a long list of the false positive cases also. And here also, like even the CT shows some thickening perineal region, even the PET CT will show some of the changes. So that's why these are actually these modalities, whether the PET CT or just a simple CT, even the MRI, they can show some changes. So they are not actually diagnostic of that particular. So that's why you have to keep in mind that everything, like I see even the nuclear medicine people, they know about it. Lot of false positive case because of the inflammation. Lot of even pleural, we think that is the extra pleural thing like of the myeloma, but they usually actually a lot of inflammation like pleuritis. Previous we know that in India there are a lot of the tuberculosis they happens in the like in the lot of the organs, some calcified lesion, granuloma here and there, and they will show this so many extra the medullary changes on PET CT. So obviously is actually very difficult to say whether it is just a myeloma or because of other pathology which happens, and we can see, we have seen this patient. So actually we have to be very, very careful to say that actually get this modality is actually, that's why I have said in the previous first time, the every modality is important. We have to be very, very like sure about what is the advantage of that particular modality, what are disadvantage, and that's why we have, but for my point of view, I always say that every modality is important, and we have to see which is important for clinical point of view. The clinical point, biochemical parameters for multiple myeloma is very, very important. You can't rely of any investigation, whether it is CT, low-dose CT, PET MRI, PET CT only. It's important, but not the whole soul, and we cannot diagnose on the any imaging modality.
Other than the what imaging modality is, interpretation is also important. You have to correlate whole picture and then put it in the differential diagnosis. Thinking of anal malignancy without any regional lymphadenopathy, going to bones and all, this overall picture we have to look into. Definitely we have to think of dual pathology in this type of cases.
Yes, sir.
Yeah, the question whether to do a biopsy of an extramedullary lesion or not. So generally, if the diagnosis is already there from the bone marrow examination, you don't require. But there are two situations which we have seen. One is if there is a lesion on the kidney. So we have seen that RCC is quite commonly associated with multiple myeloma. So then you require a biopsy from there. And the second is prostate. Myeloma also happens in the elderly, and both prostate malignancy as well as myeloma sometimes have the same kind of a presentation. So if the your PET CT scan, although it is a PSMA which is good for prostate, but if the PET CT scan is also showing something on prostate, so these are the two malignancies where I would say that it is preferably to do biopsy of those extramedullary lesions.
Sir, alkaline phosphatase usually is increased in metastasis significantly. How far is it, reliable in differentiating it with multiple myeloma usually?
So yeah, myeloma alkaline phosphatase is generally normal, at presentation, because there is osteoclastic activity and not osteoblastic activity. But as soon as you start the patient on treatment, the alkaline phosphatase actually goes up because there is osteoblastic activity which is now happening. Whereas at presentation it would be high in prostate malignancy.
Yes.
Yeah. But again, these are
Clues. They are clues towards that. That's are not.
They are not absolute.
Yes.
They are not absolute.
But sometimes in multiple myeloma with fracture, sometimes there is a mild elevation of alkaline phosphatase. Because of this, everybody's there. Our consensus is, or all modalities, I think we should take into consideration before you make any diagnosis. No single test is foolproof to say it is this disease. Okay, so ultimately we have to follow that one, because I think this is only one area. We need all specialties.
I agree,
Everybody has their role. Otherwise, we can't diagnose. A pathologist is mandatory. A radiologist is mandatory. A nuclear physician is mandatory. And at the same time, a biochemist also is mandatory, and ultimately patient, of course, a clinician patient also. So we have to take into consideration everything, then only we can make a.
Yeah. So just to conclude this particular case, basically this patient underwent a FAPI. I would like to ask Sunita right now. Let's assume that the patient was diagnosed multiple myeloma. She's been started on treatment. Now we need to assess response, because FAPI scan actually showed certain lesions which showed an uptake and certain lesions did not show an uptake. So if we have to assess response to this patient, do we go ahead with an MRI now, or do we go ahead with a PET scan?
I think we should go ahead with MRI. Point one is because it did some of the lesions were not the uptake was not present, and as a baseline investigation also it will be helpful in future assessment the marrow changes and how would it go about. I think if a PET MRI would have been there, I think that would be the best situation, but I think that's my take.
Nadik sir, if at all if the patient underwent a FAPI again, how do we assess response in this patient?
Comfortable with I'm not comfortable with FAPI in myeloma. I don't have much experience also. I would prefer FDG. One, because it's universally available, and secondly, we are more experienced in response assessment with FDG rather than FAPI. And FAPI has its limitations, like if there is some fibrosis and all, how do you really assess? I don't know. So I don't prefer FAPI in a situation like this. I would always prefer a FDG. If the patient has undergone already a FAPI, in the follow-up, it's clinician's prerogative to order, but if they have most of the cases, they will order for an FDG only. Then it becomes our, in practical scenario I'm telling, they will order FDG in the follow-up, and it becomes little difficult to say whether it has responded or not. So we have to spend more time on lesion analysis.
Exactly.
I think I'd like to add that. See, FOPI is something which is, I will put that as a third group of radiopharmaceuticals which may have to be considered for multiple myeloma. Obviously, as of today, most of the nuclear physicians, clinicians, and worldwide literature is towards FDG. The second, if at all, if you are looking for an alternate to FDG for low metabolically active tumors, we will be going more towards an amino acid. So, or radiopharmaceutical like choline. Then only pentoxifer and FOPI comes. So, I personally feel, I think for the panel discussion and for everyone to understand and to put it into their mind, FDG should be the imaging modality of choice. And obviously, it is much easier to look for the response with FDG. And possibly, I will definitely vote for whole body FDG PET CT because it is available everywhere, more than the MRI, because the therapy response assessment, I feel FDG PET is much easier to understand and to establish the therapy response.
Thank you so much. I'll go to the next case. I'll be a little fast in this because nothing.
He's saying 2 minutes or something.
No, sir, just we need to 10
Wind
minutes.
it
On
Yeah. But the dictum here is whatever imaging modality we have used at the time of diagnosis, for the response also better to use the same modality. But there is a dictum because we can't assess this.
Absolutely right, sir. Only problem is now, as of today, as Dr. Murali also highlighted, FOPI has not been established as a radiopharmaceutical where you can really look forward for the therapy response.
Apart from our biochemical response and pathological response or imagological response, we use the same modalities.
Sir, as a nuclear medicine physician, my job is to tell you whether my findings are corroborating your findings. Okay, now on a tracer like FAPI, where I am only not sure, in the follow-up also, and I will definitely not prefer. I will definitely prefer an FDG over FAPI or.
Yeah. And only thing I think this is I agree with the sir that the modality should be same whether at the time of starting of treatment and the obviously, but even the this is for the people who are the group the myeloma group, that even for the starting of the treatment they advise the low dose CT scan, and for the evaluation follow up they advising the PET CT and MRI. So still I think we need to be conscious for that also, whether we cannot be mix up the two modality, one for the diagnosis and second for the follow up. So that's so. Yes.
Right? So you can use any of those, and actually, I mean, these were also used in smoldering myeloma to actually define who are the patients who are actually having myeloma. and who are having smoldering myeloma. So the FDG, PET or MR are used in those settings where you are not absolutely sure. If you already have bony lesions, then for diagnostic purposes, imaging has no role at all. Then you are trying to look at the prognostication, whether or not there are extramedullary lesions. And these are seen in about 18 to 20% patients. So it's a question of what are you looking at and why are you looking at. So if you already have a fracture and if you have bony lesions on a routine X-ray, you don't need an imaging to actually make a diagnosis of myeloma because bony lesions are present. Here you need it to actually prognosticate and see how many are there. Again, in follow-up, it's very difficult to heal bony lesions. So what you are going to look at in a follow-up is whether or not they are active. And activity is seen from PET scans. So even if you have not done a PET scan in the beginning because there was an overt disease, after the treatment you're doing PET scan to see whether or not there are active bony lesions. So you can actually change your line of investigation in that setting. And I think the most important investigation in this patient would be do a serum protein electrophoresis, look at that report, do a bone marrow, because you already have a bony lesion. You already have anemia in this patient. So you already have two things. You have to go for myeloma in this particular patient.
Thank you, sir. I'll go to the next case now. It's a 56-year-old female, known case of multiple myeloma, was diagnosed in September 2013. Her serum electrophoresis showed M spike, bone marrow showed 60% of plasma cells. She was FISH positive for deletion of 13q14.3. Completed induction chemo followed by MRI done later showed a partial response. Modified VDD regimen was done, and PET CT in 2014 showed stage 1A disease. And she underwent a bone marrow transplant in 2014. So the first image here, I don't have the PET image of this patient, but the CT image was done, but she underwent a PET CT that showed no disease. The next follow-up in 2018 showed one focal uptake in the already present L1 vertebra, which she had a lesion, which was kept on follow-up, and then again in the 2019, again it showed increased uptake. In 2019, she underwent a flow cytometry, which was normal, and but in 2019 they picked up another lesion in the pubic bone. How do we go about investigating in this patient? I would pose this question to Nagraj sir. Oh, sorry,
Yeah, same thing, madam. Already this patient received induction therapy followed by transplantation. There is standard of care now. Now the patient is, and after 3-4 years, the patient has some clinical progression probably. Does she have any pain, madam?
She doesn't have, she's asymptomatic, sir. But what I particularly wanted to ask is, in a patient with autologous stem cell transplant, after the transplant, how many years later do we repeat the imaging?
Actually,
and what is the,
frankly speaking, as I said, we don't repeat any imaging unnecessarily. Everything is into this clinical based. Something patient is complaining something, we'll do that one. But usually we'll do follow up with this protein electrophoresis, light chain assay. Biochemical assessment will be there. We don't do any imaging, madam, unless patient complains something.
Okay.
The biochemical relapse. Then we'll do the imaging.
With myeloma is dependent upon
biochemical.
what the patient tells you.
Complaining what we are looking for.
Yes.
Because
so was this
the imaging workshop? That is a problem. We are concentrating more on imaging than the other parts.
The other part.
Because an imaging workshop, sir. I think that's because of that we are not.
I think this point is very important for a interpretation point of view also. In the follow-up, if there is no biochemical response, and on a PET CT, if we say some spot is there, then I should raise more of a non-specific uptake rather than calling it as a lesion. See, nowadays clinician may not order for an investigation, but the patients only are hyper reactive and they will come directly without prescription. This is happening, I'm telling you practically. So in such situations, if I see a lesion and if I don't have a biochemical proof of relapse, and if the patient is asymptomatic, then I should always be guarded in calling that lesion as a true lesion, or whether to say a non-specific lesion, or I will say I may ask for another MRI
So
or
my
a
question
follow-up.
here is that L1 lesion which she initially had,
Yeah, that's what.
that is showing an uptick.
That's what I am
So
telling.
how?
That uptake may not be true uptake. See, any fracture.
And with an additional uptake in the pubic bone, still
No,
you
no.
would not.
Even then. See, all these patients are osteoporotic. They are at risk for collapse, and this L1 vertebral uptake can be just a reparative response. We know FDG uptake is non-specific. It's a screening tool rather than a diagnostic tool.
Sure,
Yeah.
sir.
So that L1 uptake may be just a non-specific uptake because of certain fracture. Stem cell transplantation is for myeloma, not for preventing osteoporosis fracture, right?
May
Yes, sir.
So IMWG recommends assessment of minimal residual disease by two methods. One is looking at the bone marrow plasma cells by flow cytometry or by NGS, and the second modality is a PET CT scan. So in this patient who has a lesions at baseline, and there are again the uptake has gone back. Let's say you have done an PET CT scan after a transplant, 3 months after the transplant. That is the general 3 months post transplant, and that has gone, and now it has reappeared. Then you would take it as a bone disease, active bone disease for myeloma, and this patient may warrant a therapy, even if the bone marrow is normal, even if the patient is biochemical in remission. So these are the IMWG recommendations, and they say because there is a
Sir, but my question is, how do you differentiate whether it was an osteoporotic fracture?
yeah. So probably you do an FNAC here. So once we are talking about the where do you do the biopsy?
That's what I am telling. That's what I am telling. It requires an
So
additional
if,
proof.
Yeah, if the nuclear medicine person says that this may be because of osteoporotic or this may not be an active myeloma. One is looking at the SUV. Let's say this SUV is 10, 12. Obviously, you would feel that this is likely to be myeloma related. And generally, if the patient had a myeloma disease at that particular area, and this has gone away and it has recurred, then you will take it as related to myeloma only. So the point which I was trying to say is that in myeloma, you have to have MRD negativity both on a PET CT scan as well as on the bone marrow, and both are not correlated. So these days, when we have a lot of medicines available, so we are basically want the patient to be in remission for as long as possible. So if the biochemically patient is in remission but PET is active, this patient is likely to relapse within few days or few months.
In fact, that's what happened. So she had a full-blown relapse. So in 2022, she had multiple lesions and marrow involvement. Coming to the case 4, 56-year-old male presented with a low back pain. MRI showed multiple skeletal lesions suspected of multiple myeloma. PET CT showed multiple skeletal lesions with extramedullary soft tissue deposits in multiple areas in the body. I posed this question to Ram Mohan sir, Radha Mohan sir, sorry. These are the two PET scans which was done at the baseline and then at the follow-up. And if you see the bone lesions are not showing an uptake, but the lesions in the soft tissue, that is extramedullary disease, is showing uptake. So how do we do assessment of response in this kind of a scenario?
The extramedullary lesion is showing activity.
Yeah, persistent activity, and bone is showing no activity.
Patient is on treatment post chemotherapy.
Post chemotherapy.
We have to think of extra hematopoiesis.
So if you see here, you see a presacral soft tissue density here, then adjacent to the renal, perirenal area, there is a soft tissue density, and that has shown a decrease in uptake. So, and the muscle, increase in the muscle uptake, which is decreased with post chemotherapy, but none of the skeletal lesions are showing any uptake presently.
The next image is presacral lesion.
Yes, presacral.
This baseline and this lower one is the post therapy. They're not showing any decreased activity, right?
Decrease. So how do we assess response? Now you have an extramedullary disease which is showing low uptake, but definitely compared to the baseline there's a decrease, and the bone lesions which is almost complete metabolic response.
It's
So
residual disease. This is. It is not completely suppressed in the extra.
so what I wanted to be very specific on this is, do you follow any guideline in assessing a response of a bone lesion and extramedullary disease in such a case? Or how do we interpret the scan? Like, do we have any formulated guidelines to interpret the scans?
It cannot, definitely we cannot label it as complete response. Extramedullary residual disease is there. I can say this is partial response. I cannot label it as complete response. Residual disease is there. Yes, extramedullary deposit.
I think the
What we
impetus
what
criteria
Dewell's criteria can be used.
Sir.
Impetus criteria.
So this is basically the three criteria can be used. One is there size reduction, or is there a complete disappearance of the anatomical lesion? It is not. That's number one. Number two is the SUV max value, whether it is coming down by more than 50% or less than 50%. Again, gives a clue to us. And obviously, the same thing can be diagnosed or can be more objectively assessed like a dual score, even though it's not established for that. So as per impetus for, especially that is for bone marrow, but same thing can be extrapolated. So obviously this is it looks to be a partial response and possibly a metabolically quiescent disease. We need to see whether the soft tissue is again becoming FTG positive or size is increasing. As of now, even the chest extramedullary disease, there is large amount of soft tissue is still there, and we have to be very cautious, although metabolically disease seems to be quiescent.
Thank you, sir. Because of
those lytic lesions in this case did not show any uptake. So even though PET is just sensitive and not specific, so the clinicians would take that that bones are disease free and they're not active.
Generally, yes. After if they were positive, FTG positive, and now they have become negative, then you will take that they have become inactive.
That is the strength of this. So baseline is very important. If baseline has shown a uptake of more than 3 or 3.5 or 4, then now it is completely negative. Obviously, that is what exactly we say metabolically inactive or metabolically quiescent disease, and that may be one of our strength when compared to an anatomical imaging modality, because that lytic lesion is going to stay even though there is no real active disease there.
The functional imaging will give us this.
My question was
so
baseline.
I can answer that. Basically, you can have heterogeneity in the FTG uptake, and one important point we need to keep in our mind is multiple myeloma is a disease. Unlike squamous cell carcinoma, here the FTG activity as of even in active disease is always most of the time very less, and that's where I showed many of the images with a highly undifferentiated tumors showing high SUVs, and lower SUVs are very much
even
possible.
in your talk.
Yes.
Yeah,
so it is very much possible.
So I think
obviously
would that make a
clinicians,
difference?
I'm sure will take
not
the
picking
osteolytic
up
lesions.
bone lesions,
That's
would
very
it make a
important.
difference? I mean, only we have picked up soft tissue lesions, so there are no active lesions to start with, only in the bones. So is it okay for the clinicians to
madam,
get
again they said the same thing. Again, we'll take it one point in the imaging. Again, we'll do the biochemical assessment also. Initial, how much the protein serum, M spike, how much light chain, again this how much it is. If we have a doubt, again we'll do the bone marrow, again we'll see the plasma cell, how many percent of the plasma cells decrease. Then again we'll do this one, but ultimately the recent advances in imaging is not only anatomical, we are able to get functional imaging. This is the most important thing. For example, if you take the lymphomas, once upon a time, I think whatever the size more than 1 centimeter, we used to take it as a disease persistence or partial response. Now the irrespective of the size, if the activity is lower, the dual is 1 or 2 or 3, now we are taking it as a complete response. So I think the oncology's principles are very simple, madam. I think as you know, if we don't define the disease properly, we'll treat extra unnecessarily. That is any oncology treatment will cause the financial burden to the patient, and most of the chemotherapy drugs will cause some secondary malignancy, secondary particular complications of the treatment, Ultimately, all these techniques will give us to define and refine the treatment in a better way to avoid unnecessary treatment and to define the better treatment for the cure. Nowadays, we are able to define the cure also with this functional imaging. So all modalities are playing a major role in defining our tailor our treatment, and at least we are declaring them they are cured. So I think there is the ultimate message we want to send across to all the audience, ma'am.
Point to remember for everyone also, like we were discussing yesterday also, that some of the lesions in the bone, it still can be a like non-FDG uptake also, they will show. So that's the important, like we always think that the FDG will show everything, like every lesion will be, we were discussing yesterday also. So not all the lesions of the multiple myeloma will be showing the FDG uptake.
All are highly sensitive but not specific.
Yes,
That's
yes.
all.
So the thing is, it's a very heterogeneous kind of, even on the PET scan, very heterogeneous. So we need to have information of what it was at baseline also, and also that is why when you're reporting on a PET scan, PET scan CR, these patients, we need to individually report on every lesion actually to say, as per the guidelines. That is why it's very cumbersome to report PET CT responses in myeloma.
That's true.
The implementation of impetus has not been followed judiciously. I think it's high time we do that.
That's what I wanted to tell, sir.
It is, most of our colleagues are including ourselves. We don't routinely use, like in lymphoma, without dual scores, the oncologist doesn't accept my report. To that level, impetus is not being implemented. So the blame is on us also. Possibly, once starts, the clinicians also starts insisting, probably it will get implemented. But the point is well taken. When you have a guideline and when you have some objective criteria, your confidence level of saying CR, PR will be much easier and much more confident.
The one question for our clinical friends is that if the relapse is the whether in the soft tissue or the bone, the treatment will remain same.
Yeah, same.
Oh,
But I
same.
think the extramedullary disease, sometimes we think it is a high risk. Okay. We do some cytogenetics, karyotyping, and fish test. Most of the times, if the extramedullary disease is more of a high risk disease, and we'll try to give the more therapy. After transplant, also we'll give something maintenance therapy in different form.
Thank you.
Yes, sir. Sir, this last case, I would hand it over the mic to you. Please go ahead, sir. And if just a request, sir, because of positive time, can we just yes, sir.
Yeah, just a 50-year-old male presenting with facial swelling in August 2022, and clinically suspected plasmacytoma. Can you go back to the baseline scan? So, first, yeah, there was a very large disease in the sinuses, and which had extended into the right orbit, and the histopathology diagnosis was made as plasmacytoma, and patient underwent, next slide please, 28 fractions of radiotherapy, and in December 2022 he complained of hematuria, 2 episodes, and swelling in the arms and legs, and one of these swellings was biopsied, and again a plasmacytoma was demonstrated. Next slide please. So in the follow-up scan we can see that the right eye lesion and the nasal cavity lesion has almost showing complete metabolic response, whereas we have multiple new sites of disease. Next slide please. So there were multiple bilateral renal lesions. Next slide. Our left atrial lesion was there. Adrenal lesions, you can see also stomach wall there is uptake, and multiple skeletal muscle and marrow uptake. So plasmacytoma of the nasal cavity, which is around 1% of the head and neck tumor, transforming into full-blown extramedullary and even medullary disease in a matter of 6 months. So maybe one of the few cases which I have come across of only extramedullary plasmacytoma.
So those are extremely difficult biology in terms of biology of the disease, and if you were to look at the molecular thing, they are always harboring very high risk cytogenetics, complex karyotype, and also at the molecular level there are various molecular abnormalities at the real
this patient, when you made a diagnosis of plasmacytoma, it must have been the biochemically the patient was normal and the bone marrow was normal. But there is a one entity which is called plasmacytoma with minimal bone marrow involvement, which basically means that the plasma cells are less than 10%, but they are clonal, and the behavior of this kind of a entity is not very clear in the literature. And one of the thing which can be done possibly in this patient at the time of presentation was to do the fish cytogenetics on the biopsy of the plasma cells which were there in the extramedullary, and the kind of a presentation which is now after 6 months multiple extramedullary kind of a thing. So as Dr. Hari said, it must be an aggressive kind of a disease with poor risk cytogenetics.
Thank you so much, sir. So before I conclude, I would just want to say that thank you for all the panelists here. And can we come to some kind of a consensus guidelines following this particular imaging conference on how to investigate, how to evaluate, and especially response assessment to myeloma? So I would share the required documents so we can come with some consensus so that we can have something as coming out of this particular forum. Thank you very much for the panelists.
I would like to request Harimanan sir to facilitate the speakers and the panelists. Nagaraj KR sir. Sadashivudu sir. Murli Nadik sir.
Thank you, sir. Thanks.
Shanmugasundaram sir. Ram Mohan Reddy sir. Mahesh Prakash sir. And Dr. Sunita. Thank you all. Now we'll break for lunch.
ಹೋಲ್ಡ್ ಮಾಡೋಕ್ಕಿಲ್ಲ ಹೋಲ್ಡ್ ಮಾಡೋಕ್ಕೆ ಹೋಲ್ಡ್ मैम
रुक जा वो एक्सेस खोलो IMC
Requesting all the participants for the quiz to please stay back in the auditorium because we are starting the quiz prelims now.
And we'll also request you to please come forward.
मैम
Can you please announce?
Yeah, all the quiz participants, please make teams of 2 members each. Come forward, space out and sit here. And please note down this Wi-Fi ID and password. Switch on your Wi-Fi's. Okay. So the password is W0. It's not O, it's 0. Ayush, where is that sheet? Sheet. So this quiz is only for post-MD residents. It is not for faculty. For their own interest, they can log in and do it, but the quiz is mainly only for residents. No, you have to find a pair for yourself. Find a partner. I'm sure there's someone else. Go around the cafeteria, you might find someone. Yeah, sure. Okay, so there's a sheet going on, it's being circulated. You have to write the names of both the members of the team. Okay, the team participants can be from the clinical hematology background or from med-onc background or for clinical or hematopathology. Okay, any combination would do. Members should be 2 per team, and you have to write the name of your college, your phone numbers, and your email IDs for both the members.
Right, so if anyone wants to use the St. John's Wi-Fi, this is the ID you have to log into, IDHN workshop as such, and then that's the password. That's W and that's a 0 and not a O, RK dollar HOP. Capital W, 0, RK dollar HOP. So just pass the sheet around fast because we will be starting it only after the teams have registered themselves. Anyone has any doubts, please raise your hand so you can switch on the mic and you can always ask us, except the last 2 rows where the mics don't work.
Hello.
I hope all of you have, yeah. We'll tell that later. But just download the Kahoot app if you have still not downloaded it. Yeah, it's capital W, 0, RK, dollar, HOP. Kahoot. Yeah, if one of you download it, that's okay.
Flash the password again once.
All right, so in the meantime, first of all, thanks to the organizers, Dr. Hari, Dr. Uday, for inviting us to conduct the quiz, Dr. Annie as part of the organizing team. I'm Dr. Nitin Yashas. I'm a consultant medical oncologist at Manipal Hospital. Very privileged to be joined by Dr. Preeti, who is a professor of hematopathology at Army Hospital R&R. So we'll be your quizmasters for the day, and we'll be taking you through the prelims as such. Now the prelims is going to be done on the Kahoot app, and there are 2 rounds of Kahoot. So it's going to be round 1 on Kahoot, and then again there's going to be a round 2. And the sum of your scores in both rounds will determine who the top 5 are who will go into the finals. So we are going to be choosing top 5 who will be going to the finals, which is at 7:45 a.m. tomorrow morning. So all of you have to report at 7:30 a.m. tomorrow morning as such for the finals. Like I said, the prelims consists of 2 rounds. Each round consists of 10 questions, multiple choice, A, B, C, D, only one single option, no negative marking as such. Actually, I can just... Right, so first and most foremost, download the Kahoot app from Play Store. We will give you a game pin to enter when we actually start. When you go there, they would ask you to enter a nickname. We want you to enter the name of one of your team members. No nicknames allowed. Messi, Ronaldo, RCB, CSK, nothing of that sort. Man U, nothing. Please enter one of the team members' name in the nickname when you enter Kahoot. Now the most important thing of Kahoot, as compared to traditional orthodox quizzing, is you have to be fast and accurate. The faster you are, the more points you get. So the way the point system is inbuilt into the app, because we are in the era of T20 cricket, 60 runs of 30 balls is more valuable than 100 of 90 balls. So if you answer 6 questions correct on 10, but you have done it the fastest, you would have got more points than someone who would have answered even 7 or 8 questions. So remember, you need to be fast and you need to be accurate. And like I said, it may seem a little unfair that a person who has answered lesser is getting more points, but like I said, we are in the era of T20 cricket. Speed matters, accuracy also matters as such. Alright, no negative marking, like I said, 2 rounds of 10 questions each. Now in the event of technical glitches from the quizmaster side, or something which happens to everyone, or if there's a controversy regarding the question which is valid by a majority, which we don't think there is going to be because everything is straightforward, we would cancel that question. Okay, Kahoot gives us the option to later recalibrate and remove that question. Alright, in the event this happens. So we are laying it out right up front. We don't expect anything such thing to happen, but in case it happens, we would be knocking that question off, and that question would not be considered for marking as such. Yes, only one of the member will enter.
I'll advise keep your phones on flight mode so that you don't get a call in between.
No, it's only once. You cannot edit.
Yeah, you can't edit the answer, so be little careful before you press. And also, team composition cannot be changed. The team partner cannot be changed tomorrow morning. Okay?
Right, so it's like, it's now or never. So if you want to change now, change now or hold your breath forever. Alright, so where is the sheet? Yeah, how many more teams left to register? Okay. Could we pass one more sheet across? Yeah. So First of all, give a big round of applause to all of yourself. Thank you so much for coming as such. We have about 21 teams taking part across the country.
those number of mutations are even higher. You can see here, this is patients in CR with transplant versus not CR in transplant. However, to my original question, when patients have a lot of mutation, what does it mean? It's bad myeloma, and the answer is not really. Their survival after relapse is no different than the survival of patients after RVD. So what it means is that patients after relapsing after transplant carrying more mutations do not have a aggressive course. They don't die early, and we again don't know the reason. And we have looked at number of data sets. In none, and there is no very good data set, but in none there's a clear evidence that transplant causes bad myeloma. And one other thing we have found that may be interesting is that when you look at the development of neoantigens, so mutation causes production of protein, which are new antigens for tumor cells. And the new antigen is very well described in solid tumors, and we all use PD-1 and PD-L1 inhibitors. Not we all are myeloma people, so we don't those things. But development of new antigen is important for developing immune responses. And we found that post-transplant, myeloma cells carry many more neoantigens. Maybe then it is more immunogenic. And this is where some of the immunotherapy may have better impact. And that's why they are not behaving as bad as we would expect it to. Again, this is first thought about it. There will be many more studies needed to prove it, but I think it's an intriguing hypothesis about it. Second component interesting would be, what does treatment do? So this is one case example. Again, Dr. Samur, he looked at post-CAR T cell relapse. This is single patient. And what happened was that this patient got CAR T, had a very good response, relapsed, got second CAR T, and had no response. And so why did that happen was the question. And for the sake of time, I won't go into all the details, but it came about that this patient at the time of relapse was not producing. If you look at soluble BCMA was high, he responded, went down, and even at the time of relapse, it never went up. So the
IC50 is 5 nanomolar. When we take into the 20 nanomolar, what proteins are altering? We are drug resistant associated markers. So in order to identify that, we again subjected to the extensive quantitative proteomic analysis of the sensitive cell multiple myeloma. One of proteomics. The proteomics quantitative proteins what we have. So when we take the multiple cells, some of them is the disease associated. To avoid the heterogeneity, we are taking the single proteomics can give the better targets. Okay, that is again the technology is evolving, and also again Dr. Munshi mentioned about the genomics data. So one of the aspect is really interesting to look at the proteogenomic analysis. So we generate from the same patient proteomics data and the genomics data, and when we integrate using the bioinformatics, that can actually give the better targets for the multiple new disease pathogenesis. We're also applying the proteogenomics to develop the new candidates, and also we are looking for the exosomal proteome alterations. Exosomes are the kind of the vesicles which are the cells generated. So those proteins also associated with the multiple myeloma diagnosis as well as the resistance. So we are also looking the exosomal proteome alterations in multiple myeloma toward the therapeutic targets. One of my students is going to present on the poster on the exosomal proteome alterations. And with this, I would like to acknowledge my collaborators, Dr. Uday, Dr. Chatterjee, Dr. Sanjeev Sharma are here, and also my students. Venkatesh has done most of the work, and Kushman, Saikir, and Sadanand are presenting the posters, and funding from my lab is from the DBT, DST, and CCS. Thank you one all, and I would like to take any questions.
For an excellent presentation, and I must apologize for the confusion that was created by a slip of a finger. Yes, Dr. Tathag.
Velu Nair for remembering this concept. Basic sciences, the basic from one of the finest clinician I saw there in FMC, and it's been a very nice exposure, and you are doing a commendable work, and I hope we can take this forward. Thank you.
Thank you, Tata. If you have any questions,
Any other questions to Dr. Shrikant? So, Dr. Shrikant, can I ask you a question? I mean, you in the end said that you will you will go back to the genomics and then proteomics together. Can you actually go back from the protein to say what genes are involved?
Okay, so you mean to say that whatever the proteomics data I have,
Yeah.
yeah, but you know that's one possibility definitely, but the proteogenomics concept is
No, no,
started in the
I understand that,
that,
but
right? So if you
even
do the
for, even for you to pick up the right kind of genes, sometimes you can go back and see what would be the likely areas that are involved through proteomics itself.
Yeah.
That's one way. The second is that Dr. Munshi actually now told us about several different variations of multiple myeloma. So if you study all of them together, then would we actually have adequate data, or would we actually like to go with, say, for example, hyperdiploid separately, the other one separately, and then see if there are any differences? Because we are also looking for, the differences in presentation in these individuals, the differences in the progression in these individuals. And I think data would come if we combine both of them, but if we have actually information right in the very beginning. So it may be a good idea actually, at least I don't know whether you agree with me or not, but it might be a good idea to have that molecular information also. Okay, I think we are on. Dr. Munshi, last minute comment. Okay, so Dr. Munshi will be talking about it later, and we are already past time, sorry.
Thank you, thank you.
Okay, so it's my great pleasure to invite Dr. Shrijesh from Chandigarh, and he is going to tell us about Indian data on TP53 aberrations in myeloma PGI experience. Shrijesh.
Very good afternoon to all of you. Thank you, sir, and thanks to the organizers for this opportunity to present our data. It's not moving. So basically, we all know that both deletion 17p as well as p53 mutation were high-risk cytogenetic abnormalities and are associated with poor outcome. And the prognosis is especially poor when there is a biallelic inactivation of the TP53 gene. Despite that, I feel most of the labs, though do TP53 deletion testing, that mutation testing is mostly not done. So coming to our data, basically this is a basically it's a combined retrospective and prospective analysis over a period of 4 years. We had 581 bone marrow samples from 566 patients, and all the samples were magnetically sorted. So the plasma cells were enriched before testing. The median age of our cohort was 60 years. There were some young myeloma patients as well. So if you see, our data basically, most of the patients presents in ISS stage 3 or RISS stage 2. So basically they present later stages. So if we apply the latest revision, actually the most of the patients were in R2 ISS 3. So basically this deletion testing was performed using a dual color probe in all these cases, and 10% was the cutoff which was used in our study. So a total of 581 patients, there were like 457 newly diagnosed multiple myeloma and 124 patients with relapsed refractory myeloma, and the deletion 17p was detected in 89 patients, that is the 15% of the whole cohort. And the frequency of positive cells, it ranged from 10% to 96%. So basically you see most of the patients have actually a higher frequency of deletion positive cells. Now in NDMM with TP53 deletion, the TP53 alone, that was the only prognostically relevant abnormality in 37%, whereas in other cases it was associated with one or other prognostically relevant cytogenetic abnormality. Similarly in relapsed refractory myeloma with TP53 deletion, that was the only prognostically important cytogenetic abnormality in 50% of patients. So basically if you see, the frequency of TP53 deletion was around 13% in newly diagnosed cases, and it was almost double, that is 24% in relapsed refractory myeloma, which is expected because the secondary cytogenetic abnormality and it's enriched and it increases during the relapse. So if you compare with other studies, you see actually one of the largest from some of the, if you compare with some of the largest data from the Western world, the frequency is still on the higher side, like 13% versus around 9%. But there are studies with the higher frequencies as well, especially there is one study from India which report as high as about 18.6%. Now coming to the TP53 mutation testing, basically these are done in, so there was a discussion on biobanking. Actually we didn't do a biobanking properly, but we had samples in a proportion of cases. So basically in this sample we did TP53 mutation by next generation sequencing. So we used an in-house AmpliSeq panel which had 24 amplicons. This is just for NGS. So basically we just tried a cost-effective NGS using 24 amplicons. The sequencing was done in Illumina mySeq, and we tried to attain at least 250x mean amplicon coverage. It was not a high depth sequencing, and we got a successful sequencing in around 285 patients, which include 244 newly diagnosed and 41 relapsed refractory myeloma cases. So at least one pathogenic variant or likely pathogenic variant was identified in 28 cases out of these 285 cases, which is like 9.8%. This translates to about 10% in newly diagnosed cases and around 7.3% in relapsed myelomas. So 22 cases had single variant, 4 cases had 2 variants, and 2 cases had 3. So these are basically multi-hit. So even in AMLs and MDS, this concept is coming because you can have multiple different kinds of mutations in the same patient. So overall 35 pathogenic or likely pathogenic variant was identified in 28 cases. If you see them like around 30% of the cases the VAF was less than 10%, and nearly more than 50% of the cases the VAF was at least 30% or higher. So overall the VAF ranged from 3.4 to 98% with a median VAF of about 32%. The most of the mutations were missense mutations and affecting the DNA binding domain. And from this heat map we can see that you see the darker shades. So the cases with the high VAF had either TP53 deletion or an aneuploidy of chromosome 17. So we can have a different combination. So almost all cases with VAF more than 45%, they either had TP53 deletion or had a aneuploidy of so basically either trisomy or a tetrasomy of chromosome number 17. So, if you see, so the 285 cases with both FISH and MGS data, you can see that at least 60% of the patients with TP53 mutation had a deletion, TP53 deletion. Vice versa, at least about 38 to 38% of cases with TP53 deletion had a TP53 mutation. The biallelic TP53 inactivation, so overall was seen in 6.6% of newly diagnosed cases and about 5% in relapsed refractory. Again, TP53 mutation data, if you compare with the Western data, the frequency is on higher side, like 10% versus around 5 to 6%, though there are studies with much higher frequencies as well. So probably if you see our data, it's not only the TP53 deletion and TP53 mutation. Our 1q21 percentage is also higher. Like we have about 55% of cases with 1q21 gain or amplification. We have higher frequency of patients in RISS3 or ISS3. So probably I feel that most of the patients are presenting at a later stages. That's why the secondary cytogenetic and genetic abnormalities are seen at a much higher frequency in our population. Now the mutation testing also helped to improve the diagnosis of double hit multiple myeloma. We know that what is double hit multiple myeloma. So without mutation testing, 89 cases had double hit multiple myeloma. So additional 9 patients were diagnosed as double hit by mutation testing. Again, we had an opportunity to see 23 cases. In 23 patients, we did cytogenetic analysis at 2 different time points because of either relapse or remission. So you can see that in 6 of these patients, the TP53 deletion was not seen at diagnosis, but they were present at different proportions during relapse. So this again highlights the importance of repeating these testing at relapse. Coming to hematological features, now the circulating plasma cells is now recognized as an independent prognostic marker in myeloma. we found a significantly higher frequency of cases with circulating plasma cells in patients with TP53 aberration compared to those without. Similarly, the plasma cell leukemia, whether we by defining it as more than 5%, that was also significantly more frequent in this patient. Interestingly, we also found that the myelofibrosis is significantly more frequent in these patients with TP53 aberrations. The details of treatment were available only in a proportion of patients because actually the study was also during that COVID time, because a lot of patients were lost to follow up. We had to call them and to calculate the overall survival. So most of the patients received 3-drug regimen, and whether we take TP53 aberration present versus absent, or a mutation present versus absent, or a deletion present versus absent, see, these patients with TP53 abnormality had a significantly poor overall survival as well as a progression-free survival, which is in concordance with any of the literature. Somehow we could not get a good separation between monoallelic versus biallelic, probably because we do not have sufficient patients with biallelic TP53 inactivation. So this table summarizes, basically these patients invariably have a poor prognosis. So to summarize, in this large cohort from India, 581 samples, TP53 deletion was seen in 13% of NDMM and nearly double, 24% of relapsed cases. Mutation was seen in 10% of newly diagnosed cases and 7% of relapsed refractory patients. We have a higher frequency compared to the Western data. Probably, as discussed, many of these patients are coming at a later stage, and these patients invariably have a poor outcome. My acknowledgements to Pankaj sir, my seniors, my student Dr. Shelley, who did a lot of compilation, and my staff and my other research students. Thank you.
Thank you. There is good time for only one question, so a question from there. Yeah.
Hi, it's Vijesh. Very nice data. I just have a basic methodology doubt. So when you did the sequencing, you extracted the DNA from the enriched plasma cell, or was it a bulk DNA extraction?
No, all these cases were using the sorted plasma cells. So that's where the number reduced. After fish testing, we didn't have sample in many cases. So we had sample on 300, in which 285 samples we could successfully do NGS.
Do you believe you would have gone for a higher depth with patients with fewer plasma cells? You would have
Definitely, I wish to do it, yes. And second problem is we didn't use a molecular ID and all. This is simple dual index sequencing. So I am not sure whether we can report less than 3% or even lower frequencies.
Less than 5% without error corrected sequencing would be difficult to call.
Okay. Dr. Munshi, for last comment? Both of you.
Quick question. Very good work, Seth. I think so. The frequency of mutation is higher than one would predict in general, and it could be local scenario or something. But do you compare or rule out the germline changes before you call the SNVs on the tumor side?
So I wish, so as I highlighted, the most of the cases with more than 40% VAV had either a TP53 deletion or they had trisomies or tetrasomies. So what I believe is probably that is the reason for the higher VAV in these cases, like 45%, 50%, 98%. But if I get a chance, I would like definitely wish to do a germline, sequencing.
Because really good work. How do you explain the relapse patients with a lower frequency of mutations?
Again, probably the sample bias. That's what I feel, because we had only 41 cases with relapsed refractory myeloma.
Thank you, Srijesh, and thank you, everyone.
We now begin our panel discussion on diagnosis of myeloma in 2022 with focus on resource constrained settings. Our moderator for this session is Dr. Pankaj Malhotra. Dr. Malhotra is Professor and Head, Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. Sir is also President, Indian Myeloma Academic Group, Member Board of Directors, International Myeloma Society. Dr. Malhotra is also the recipient of the ICMR Award of Young Indian Scientist to Mayo Clinic, Rochester, and CML Fellowship, Oregon Health and Science University, Portland. I invite Dr. Pankaj Malhotra to introduce the panelists.
Good afternoon. There is, I think, some problem with the slides, but what I can do is just what I would do is, till the time they are sorting out the slides, I can invite the my panelist for this panel discussion. Dr. Jeevan from TMC Kolkata. Dr. Nikhil Munshi, please sir. Dr. Rachana. Dr. Sairek, Dr. Sumit, Dr. Ankur Huja, and Dr. Tathagat Chatterjee. So although we are running late, but probably what we will do is the topic is the diagnosis of myeloma with focus on resource constrained setting. What I would do is it will take waste another 10-15 minutes. I can present just like that only, instead of it's what we are talking is that when we are making a diagnosis of multiple myeloma in a resource constrained setting, and in our clinic we get many patients who says that I cannot afford a PET CT scan, I cannot afford this. So how do we reach how do we plan the investigation so that we do a minimum set of investigations in a patient who is really financially not affordable, and and at many centers we may not have all the tests like NGS and fish test, so that we don't waste too much of time for initiating the treatment, and where we feel that the patient has all the means, and we do all whatever is recommended kind of investigations and treatment. So what we would do is so we will divide the kind of investigations into minimal, optimal, and extended. What is the minimum investigation, what is the optimal, and what is the extended investigations. I hope everybody can remember the things. That 45 years old gentleman who has presented with a recent onset anemia, hemoglobin of 9. His previous best was 14 grams, so that there is a fall of hemoglobin of around 5 gram or so in recent time. On further investigation, there was a reversal of AG ratio. Wow, yes, there you go. So there was a reversal of AG ratio, and M band was 4 gram, IFE was IgG lambda, and serum creatinine was normal. So, okay. So the first is, always we had a debate in the morning also, and some of you may be present. The first is the radiology. What we do, either skeletal survey, ultra low dose whole body CT scan, diffusion weighted MRI of the whole body, or a PET CT scan. And maybe I can start from Dr. Jeevan. What do you do, and how do you, what is your practice? So it is all, our practice. We are not discussing the theory, we are discussing the practical aspects of, looking at the minimal investigations, optimal and extended.
Yeah, sir, if it is only the minimum, then we can do our old investigation like skeletal survey. We were starting with the skull x-ray, x-ray of the pelvis, spine x-ray, and the x-ray of the long bones. And in the optimum, it should be low dose whole body CT scan, or it may be MRI. And in the extended also we can do whole body MRI. And if we have any doubt of extramedullary myeloma, then PET CT scan should be preferred.
Okay, I think that's very fair enough. And Dr. Rachna?
So in our practice, we are generally getting a PET CT scan done for most of our patients. But if you are speaking about the patients who are not affordable, we are getting at least the skeletal survey done. That is the minimal investigation in the radiology point of view we are doing. So
Okay. Do you have an ultra low dose whole body CT scan
No,
at your
sir.
center? You don't have. Okay. Dr. Sairek?
Also, I think we also go with the same pattern that for those patients who can afford, we'll go for the PET CT scan. For those patients who have financial constraints, we go for skeletal survey alone. We also don't have the ultra low dose CT scan.
Okay, okay. And yes, Dr. Tataghat and Dr. Ankur are lab person. So, who is left? Dr. Sumit, yeah. What do you do in your
Skeletal
practice?
survey minimal,
Mhm.
low dose, low whole body CT scan as optimal, and in ideal setting PET CT and diffusion weighted MRI.
Okay.
We ideally get PET CT get done for everyone, but if resources are serious issue, then ultra low dose whole body CT if possible. If not, then skeletal survey.
So, do you get, let's say somebody can say ki I can afford, so do you get ultra low dose whole body CT, PET CT and MRI all together, or no?
No, only whole body PET CT in that case.
Then you do only the PET CT. So maybe we can now listen
Unless
to.
it's suspecting a marrow or spinal cord involvement, in that case we'll do MRI.
So what is the practice in US? What do you do in your practice?
Practice in USA, you don't want to know. But I'm going to ask a little bit different question, because we're trying to do minimum. And I was born and raised and studied here, so I know our setting quite well, although it was quite a long time ago. And people can really not even afford skeletal survey, I think. So the reason we do this to decide whether he or she has myeloma or not, and I'm going to treat. So if this patient has hemoglobin of 9 with no other cause, do we need any imaging? We want to see what one does in the practice, and probably not. And then if there are no bone-related questions, would you do anything? This is extreme economic thing, but I think there are large number, and so I think there is something less than minimum also where you could decide we don't need it. In our place, we do skeletal survey, not always anymore. PET CT is more common. Other two are available, but they're more selective for various other reasons. But usually PET scan and skeletal survey depending upon the need.
Okay. One of the thing, I don't know what is the experience of other people, and I would actually like to listen to you. When you do a PET CT scan in many of these patients, many times you get lytic areas which are non-FDG avid. Do you get that? So how do you interpret those kind of reports which are non-FDG avid? This is we are talking at the time of diagnosis. So Dr. Jeevan, do you get that kind of a report in your practice?
Yeah, definitely, sir. We are getting that kind of report. But majority of cases, if it is multiple myeloma and we have if multiple non-FDG area also, then also treatment would not change. The main problem occurs in case of solitary plasmacytoma. So if we have any doubt that there is some other lesion, then we can do FNSC or biopsy from that area. But in myeloma, it doesn't change.
Okay. Dr. Rachna.
We do get some reports which show that there is no uptake, but there are lytic lesions in the bones.
Yeah.
So we are still considering them to fit into the CRAB criteria, the lytic bone lesions, and so our management is not changing just based on the metabolic uptake of the PET CT.
Okay. Okay. Anything different or?
Yeah, if that is only just one lytic lesion, which might be the CRAB defining area, and if the HB hemoglobin everything is fine, then we might go for a biopsy then. Otherwise, we would take it if there are other CRAB criteria, and if everything else fits into a myeloma, we wouldn't biopsy. We would take it as a lytic lesion.
Okay. So basically, what I want to
add something?
Yes, sir.
So actually, in fact, between 11 and 14% of myeloma are PET negative. And so they would have clear bone lesions or other lesion, and they're not positive on PET. So there's a clear entity. In 10+%, it's a reasonable number. And there's also, that's where genomics comes into picture. There's also explanation why. So those patients have deficiency in myeloma cell of enzyme called exokinase, which is required for conversion of glucose and utilization of glucose. And so exokinase negative myeloma ends up being PET negative. So it's quite often present, and this is when you might want to do MRI or other alternative if you still need to find out if what's happening. Rarely, and we have a need where other malignancies are possibility, you may need to do it, although other malignancies are more often positive than myeloma.
And that's actually the reason for asking this question is that in the morning when we were in the radiology workshop, we were discussing that hardly anybody is using impetus criteria which are there for the only Italian criteria which are there for interpreting PET CT scan in myeloma, but hardly anybody is following. And one of the other questions which was being discussed was that probably Pentixa 4 based scanning is maybe more useful in myeloma patients than FDG avidity, and you have rightly said some of those because of the glucose 6 hexokinase and these may not be FDG avid. But yes, anything, Sumit, you want to add anything on?
One more point is also that a PET positive myeloma can become negative in future on follow-up. So
yes,
it wouldn't always remain positive. They can lose it.
They can become negative. Right. So okay, so I think the take-home message is that if all other criteria are getting fulfilled, like you have bone marrow plasma cells more than 60%, anemia, calcium is high. So even if says the patient is not affordable for even skeletal survey, he is myeloma patient only. But I think at least skeletal survey, X-ray skull, at least I think people can do, that is the minimum. But optimal is if you can do an ultra low dose whole body CT scan, that is the second thing. PET CT scan, I would put it into an extended investigations, and especially as Dr. Jeevan said, where you are thinking that there is an extramedullary disease and that can change the prognosis of the patient, probably you would like to do, or where you want to look at the MRD negative status both in the bone marrow as well as on the PET CT scan, there probably you would like to have a baseline PET CT scan. All right. So this is what minimal optimal